It's a little bit after 9, so we'll go ahead and get the process started here. Thank you all for your attendance. I'm going to start. I have introductions. I'm not going to introduce the panel. I'm not going to have us introduce ourselves because we kind of know each other. But the staff here is very important. They make us look good. They do volumes of work, and I want them to be at least recognized. So let's start with our committee assistant, Gary, and work around the table.
What do you want from us?
Just a quick introduction, name, and what your purpose here is.
Okay, Gary Dieter, committee assistant, and I live in the wilds of North Topeka.
Megan Leopold, fiscal analyst with Kansas Legislative Research.
Dayton Lemunian, fiscal analyst with Legislative Research.
Scott Abbott, Office of Revisor of Statutes.
Jesse, here to assist Scott.
Travis Rose, AV Specialist.
Thank you, all. And we couldn't do this without you. Like I say, they make us look good and they make our jobs look easy. Special thanks to Megan, the researcher on this, for her job as facilitator, putting this all together and getting the timelines, everything. As many of you recall, we put a proviso in the 23 budget to look at the rates for long-term care homes and the methodology therein. And many of you know we're always kind of playing catch-up. A lot of these homes are working at a deficit on a large population or a large percentage of their population. Some as many as 95% of their residents are on Medicaid, and those rates have been woefully lacking historically, and we're always just playing catch-up. So this is a look at how we might proceed down the road. Is there a better way? I keep asking myself that, and the answer I keep getting in my head is there's got to be a better way to do this. So we're going to see what we can find out today. And with that in mind, I'm going to start with our first presenter. And it's basically, if y'all have the agenda, it's an overview of nursing facility rate review in other states. And this is a presenter on WebEx. So are you with us?
Yes, thank you, Chairman Mason. Can you hear me and see me okay?
We can hear you. We can't see you yet. We'll work on that. There, now we can see you. Thank you. Please proceed.
Thank you, Chairman Mason and Madam Vice Chair, for inviting me here to speak today. My name is Catherine Costanza, and I'm a program principal with the National Conference of State Legislatures. And I will go ahead and start sharing my screen to start the presentation. All right, can you see the slides okay?
Yes, we can.
Excellent. Okay. Thank you very much. So today I'll be providing a high-level overview of Medicaid nursing facility payments and the review processes that different states have put in place to review and update those nursing facility payments. So before we dig in, I just want to start by introducing us if you're not familiar. So the National Conference of State Legislatures is your nonpartisan and bipartisan professional membership organization. And we serve the over 7,000 legislators and 30,000 legislative staff in all 50 states, the District of Columbia, and the territories, with all the services listed on this slide, including policy research and technical assistance presentations like this one. So today we're going to cover a brief introduction to the fundamentals of Medicaid payment generally, an overview of what goes into nursing facility payments, a national overview of how states pay nursing facilities, and finally take a look at 6 state examples of the Medicaid rate review processes for nursing facilities in those states. So let's dig right in. To get started, we're going to get oriented to the fundamentals of provider payments in the Medicaid program. So as you are aware, the Medicaid program is a public health coverage program that is jointly funded and regulated by both the federal and state governments. And this diagram provides an oversimplified overview of the federal and state roles in the Medicaid program. And federal actors, including Congress and the Centers for Medicare and Medicaid Services, or CMS, are at the top. State actors, including yourselves as the legislature and the state Medicaid agency, are in the middle. And constituents impacted by the program include patients, providers that provide Medicaid services, and vendors, including managed care organizations, are at the bottom. And for now, we're going to focus mostly on the green arrow here, which is going to show how payment flows through the Medicaid program. So the way that payments flow through the Medicaid program is that Congress at the federal level at the top makes appropriations to the Centers for Medicare and Medicaid Services, which then determines the federal matching rate and shares those funds down to the state Medicaid agency. At the state level, yourselves as the state legislature also make appropriations to the state Medicaid agency to fund the program. And from there, the state Medicaid agency establishes rate schedules and fees and either pays providers directly or pays them through managed care organizations, which then pay providers themselves. And that's roughly how payments flow through the Medicaid program. So it really depends on how payments flow through the Medicaid program to providers does depend on whether the state Medicaid agency itself is responsible for payments to providers or whether it delegates and pays another vendor like a managed care organization to be responsible for those payments. And there's all these other different aspects of regulation, oversight, data collection, the actual health services at the very bottom left of the screen here, and innovations that flow through the program as well. So because the Medicaid program is jointly funded and regulated by the federal and state governments, there are different federal requirements and state flexibilities for different functions. So states have pretty considerable flexibility in their provider payment systems within very broad federal requirements that Medicaid provider payments be consistent with principles of efficiency, economy, and sufficient to provide access to care. However, state flexibilities vary a bit based on the delivery system and the provider type. So as we just talked about, states have the most flexibility and control in those state-operated Medicaid delivery systems because the state agency establishes the payment rates for providers directly through the state agency and is directly responsible for paying providers. However, when the state delegates some or all of its functions to the Medicaid program to private commercial insurers, which are known as managed care organizations, those managed care organizations are responsible for establishing provider payment rates and methodologies in the contract between the managed care organization and the provider. And managed care organizations may tie their payment rates to the state's fee schedules or the state's methodology, but they do retain control to change that and to adjust payment rates, unless the state regulates otherwise. It's also important to note that states pay and regulate the Medicaid MCOs themselves, those managed care organizations, which can influence how managed care organizations pay providers. There are also some additional federal payment rules that apply to certain provider types, specifically hospitals and federally qualified health centers, but we're not going to discuss those in detail here because they don't necessarily apply to nursing facilities. And finally, most states make supplemental payments to providers, mostly to hospitals and to nursing facilities. And there are some limitations on supplemental payments. These are typically intended to raise provider rates, but they cannot exceed similar Medicare rates for the same provider type, which is sometimes called the upper payment limit. So there are some limitations on how much states can supplement the underlying rates that are in the state fee schedule or that are paid by managed care organizations. So now that we have the basics on Medicaid payment, let's get oriented to how nursing facility payments are set and work in the Medicaid program. And first, I think it's helpful to just have to clarify what it is that we're talking about when we're talking about nursing facilities enrolled in the Medicaid program. So Nursing facilities are institutions certified by the state to offer 24-hour medical and skilled nursing care, rehabilitation, or health-related services to individuals who do not require hospital care. And I want to point this out because this does differentiate them from assisted living facilities or adult day centers or intermediate care facilities for people with intellectual and developmental disabilities. Those facilities will have separate fee schedules, and they do not offer this full scope of services that are usually provided by nursing facilities. Nursing facility services are also a mandatory benefit in the Medicaid program, so they're required to be provided by the state. And they are also the second largest category of Medicaid spending after hospital services. Medicaid is the primary payer for nursing facility care in the country. However, approximately 84% of Medicaid covered nursing facility residents are eligible for both the Medicaid program and the Medicare program. And for these individuals, Medicare will pay for skilled nursing care for the first 100 days of care, and Medicaid itself pays for the subsequent days of care after the Medicare benefit is exhausted. And both the Medicare and Medicaid programs have a joint responsibility for monitoring the quality and safety of care provided in nursing facilities. So when we're talking about nursing facility payments, it's important to differentiate between how payments are operated in the different Medicaid delivery systems, the fee-for-service system and managed long-term services and supports, which are sometimes called MLTSS. I'll try to keep the acronyms light in this one. So in state-operated or fee-for-service, on the left-hand side here, the state is directly responsible for establishing the nursing facility benefit, paying nursing facilities, and setting the payment rates and methodologies for nursing facilities. In managed long-term services and supports, the state contracts with that private commercial insurer, that managed care organization, and is delegating responsibility for administering both the nursing facility and home and community-based services benefits, for paying nursing facilities, and for setting nursing facility payment rates and methodologies. But an important caveat here is that payment rates and methodologies in managed long-term care may also be linked to fee-for-service rates set by the state. This may happen either because it's legislatively or regulatorily required by the state that the managed long-term services and supports be linked to fee-for-service rates, or it may be because managed care organizations don't have the capacity to develop their own independent payment methodologies. So when we're looking at nursing facility payment rates in different states and how states review and set those rates, fee-for-service continues to be important even in states that have managed long-term services and supports. So because, as I mentioned, because fee-for-service is often the way that rates are set in even managed long-term services and supports programs, we're going to briefly review what goes into nursing facility payment rates. So this information is primarily taken from a comprehensive 50-state survey of nursing facility payment policies conducted by the Medicaid and CHIP Payment and Access Commission, which is a nonpartisan policy research organization that advises Congress on issues related to the Medicaid program. And please note that nursing facility payments are complex methodologies, so we're just going to be covering the high-level basics. So at a high level, there are 5 primary components to nursing facility payment methodologies. First, we have the base rates, and these account for the frequency and underlying basis for determining facility rates. So all 50 states, as of this MACPAC survey, pay nursing facilities a per diem or per day set fee. And most states base that daily per diem on either facility costs, a specific allowable price, or a combination of those two things. So states also review and update these base rates for facilities, which is sometimes called rebasing, annually or on some other time frame. And we'll also discuss this further in the national landscape and state examples sections. And Primary cost centers are the way that states evaluate how, what it costs to operate a nursing care facility. And it's the cost and rate components that are used in calculating payments to nursing facilities. And these primary cost centers can include things like staffing and salaries, medical supplies, social services and patient activities, administrative expenses, and capital costs associated with the physical building itself, like fair rental value, depreciation, and property taxes. Third, adjustments are exactly what they sound like. They're adjustments to the base payments to account for unique facility characteristics, like for rural located nursing facilities, or nursing facilities that are owned and operated by a government entity, either by the state or by maybe a municipality. The level of, and sometimes adjustments can also account for the level of care needed for higher acuity patients, like those with dementia or Alzheimer's disease. Fourth, supplemental payments, as we talked about, are those additional payments made to nursing facilities to increase the overall payment rate or make up the difference between Medicaid rates and equivalent Medicare rates. And these are often funded through provider taxes or funding from local governments instead of through the state general fund. And finally, incentive payments account for payments to address quality and efficiency and incentivize higher performing or higher quality care. And these can include value-based payments, pay for performance, or other types of payment models. It's also important to get a high-level introduction to the way that states pay managed care organizations to administer the state's long-term services and supports programs. So this is not the focus of this testimony, so we're not going to linger on all the details here, but I want to point out that I've linked to some resources here in this slide that contain multi-state surveys and information on how states have approached rate setting for managed long-term services and supports as well. So first, it's important to note that payments to managed long-term services and supports organizations are capitated, which means that they are paid by the state to the managed care organization on a per member per month basis. And these rates are set in advance and must be actuarially sound. Second, these rates are also risk adjusted to account for the health status of the enrollee. And this may be based on the functional status of the enrollee, such as their ability to perform certain activities of daily living, but it can be tricky to find the right data. Tricky to find the right data to use to appropriately risk adjust rates. Third, the capitated payment rate paid to managed care organizations accounts for both institutional care provided in nursing facilities and other institutional settings and home and community-based care. So the capitated payment rate that these organizations receive is a blended rate, regardless of the setting of care, and can be structured to incentivize managed care organizations to provide more care in the community rather than in institutions. However, if the rates are not blended to account for the right amount of institutional care, managed care organizations are at risk for those costs, and it can impact the financial stability of the managed care organization or can incentivize them to control costs in other ways, which may include cutting provider payment rates or other things like that. 4, directed payments are essentially supplemental payments, but they're in the managed care world, in the managed care delivery system instead of state operated. And this is a way for states to direct managed care providers to increase or supplement payments for nursing facilities. And finally, it's also important to note that many states use these capitated managed long-term services and supports programs to support those beneficiaries who are eligible for both Medicare and Medicaid and integrate and coordinate care for those individuals as well. So before we dive into how states review rates for nursing facilities, we'll take a quick look at the national landscape for nursing facility payments overall. So in the fee-for-service delivery system, 22 states rebase costs annually, whereas 12 states rebase those costs every 2 to 4 years. The remaining state Medicaid programs either do not specify a rebasing frequency or they rebase costs less often than every 4 years. One consideration for policymakers is that states that do not rebase nursing facility costs frequently enough may risk paying facilities outdated amounts that may not account for inflation and other changes in costs. Additionally, 23 states made supplemental payments to nursing facilities in the fee-for-service program, and 20 states and the District of Columbia make quality incentive payments to nursing facilities through pay-for-performance methodologies. So essentially, providers receive either some shared savings or they receive a bonus for meeting certain quality metrics. Now, as we move to manage long-term services and supports, as of November 2022, the 24 states highlighted on this map in green paid for some or all nursing facility care through managed long-term services and supports. The 2 states highlighted in orange also used managed long-term services to pay for care for dual eligibles, or those people who are eligible for both Medicare and Medicaid. And the 2 jurisdictions in brown, Indiana and DC, are actively developing a managed long-term services and supports program. And in managed long-term services and supports, 14 states have established minimum fee schedules for nursing facility services and managed care, and 6 states require directed payments for nursing facilities in managed care. And now we're going to dig into the state Medicaid rate review processes in 6 states. And for this, I've selected 3 states that have fee-for-service and pay nursing facilities through fee-for-service, and 3 states that pay nursing facilities through managed long-term services and supports to provide a mix. And before we dig into this, I want to point out that the Medicaid rate review processes reflect a mix of both executive and legislative branch actions, which can include things like studies or dedicated rate development units, or just simple practices that are included for the state, such as annual rebasing. So first we'll start with Arkansas. So Arkansas is a state that pays nursing facilities through managed long-term services and supports. Pursuant to Executive Order 1902, signed by Governor Asa Hutchinson, Arkansas conducted rate reviews between 2019 to 2021 for certain providers, which included intermediate care facilities and assisted living facilities, but did not include nursing facilities and does not appear to have continued. However, the state maintains payment rules through the Office of Long-Term Care Cost Reimbursement, which were updated as recently as 2022, and the state rebases their nursing facility per diem payments annually. Colorado pays nursing facilities through the state's fee-for-service delivery system. And Colorado statutes directly address nursing facility rate reviews and specify the frequency with which the state agency is required to review and update certain elements of nursing facility rates. So, for example, facilities are required to submit cost reports to the state annually, which are used to redetermine the per diem rate paid to providers. Additionally, the state calculates supplemental payments annually, and starting in 2023, the state agency is required to annually adjust rates to ensure access to care for residents with severe mental health conditions. Beyond nursing facilities, Colorado also requires the state Medicaid agency to review all other provider rates for every provider type, including home and community-based services, every 3 years. And the agency is required to analyze these results for service use, access, and quality, and publish public reports on the topic. The agency does not review nursing facility rates under this process because the authorizing statute permits the agency to exclude payments that are otherwise reviewed more frequently according to state law. And as we just heard, nursing facility rates are adjusted annually. But as a part of this provider rate review process, the state has also convened a Medicaid Provider Rate Review Advisory Committee that facilitates stakeholder participation and input into the provider rate setting process. So, for example, in 2021, the Stakeholder Advisory Committee noted that it did not agree with the findings of the rate review report for transportation services. So that's an example of how the state both reviews nursing facility payments, but also other provider rates in the Medicaid program. Iowa is a state that pays nursing facilities through managed long-term services and supports. And it rebases rates every 2 years. And managed care organizations are required to reconcile their rates according to when the state rebases its rates. The agency was directed in Appropriations Bill House File 891 in 2021 to evaluate the nursing facility case mix reimbursement and rebasing processes. And I've included a link to the results of that study. And in the 2023 legislative session, 2 bills were introduced but not passed. One bill would have required the agency to rebase nursing facility rates in 2023 and required semi-annual adjustment. And another bill would have set fee-for-service rates as the floor for managed care reimbursement, but neither have passed. Missouri is a state that pays nursing facilities through fee-for-service. And Missouri publishes annual reports on facility rates in the state's Access and Monitoring Review Plan, which reviews the state's fee-for-service payments to determine whether rates are sufficient to support access to care, including for nursing facilities. However, it does not apply to managed care payments to providers. And most recently, nursing facility payments in Missouri were rebased in 2022 based on 2019 cost report data. But prior to this, nursing facility payments were last rebased in 2005 based on 2001 cost report data. So this is the most recent adjustment since 2005. Additionally, the state permits the agency to adjust to make a global per diem rate adjustment. So some global adjustment to the underlying fees, but only if approved by the General Assembly and by the governor. Nevada also has a fee-for-service system and pays nursing facilities through the state. And Nevada requires rate reviews every 4 years for each service or item covered under the state plan. So Nevada created something called the Rate Analysis and Development Unit to conduct rate studies and reviews and analyze the fiscal impact of rate changes for both Medicaid fee-for-service and Medicaid managed care capitated rates. And this was established in Nevada Revised Statute 422.2704, which is linked here as well. New Mexico is another state that pays nursing facilities through managed long-term services and supports. And in 2022, the New Mexico Medicaid Agency published a provider rate benchmarking study that evaluated nursing facility rates against Medicare and against other state Medicaid program benchmarks where available. Although it can be challenging to compare these state Medicaid program benchmarks because it can often be like comparing apples to oranges. For the limited services that the state could compare to Medicare rates, the study found that New Mexico reimbursement was lower than Medicare rates for most services, but above equivalent Medicare rates for inpatient psychiatric and rehabilitation hospitals. Additionally, the study compared managed care payments as a percentage of fee-for-service equivalent payments and found that managed care organizations paid nursing facilities between 97% to 114% of equivalent fee-for-service rates. So pretty on par or greater than equivalent fee-for-service rates. Also, in the 2023 legislative session, HB 395 required the agency to conduct biannual cost studies to recommend reimbursement rates for all providers who support services required by people with developmental disabilities. So this may include nursing facility care, but also care provided in both the home and community and in other institutional settings that serve people with developmental disabilities. And with that, I just want to point out that we will soon have an upcoming webinar of nursing facility on nursing facility payments. We also have a Medicaid toolkit and a database that covers Medicaid and marketplace legislation, including things on Medicaid nursing facility payments. You can always stay connected with NCSL research by subscribing to the Health and Human Services link and Health Systems Digest. and signing up at the link here. You can stay connected with us in a lot of ways, and I'm sorry for this. I'm required to include this. We also have an upcoming base camp session November 8th through 9th and NCSL forecast in December 2023. And with that, you can reach out to me anytime with questions about Medicaid. Happy to answer anything. And thank you so much for allowing us to join you today.
Thank you, Catherine. You will take some questions, I assume?
Yes, absolutely.
Okay, first off is Senator Gossage.
Catherine, thank you for being here. We've met at the NCSL several times on the Health Committee. Question that I have for you is on your slide regarding managed long-term care services and support payments, you mentioned that 14 states established a minimum fee schedule and 6 states required direct payments for nursing facilities. Can you tell me which are we?
Thank you, Senator. Thank you, Chairman, and thank you, Senator Gossage. I could not tell you off the top of my head, but I can find out and let you know that information.
And perhaps our own staff here can tell us when it's their turn to speak. Thank you, and thank you, Mr. Chair.
Committee, other questions? Seeing none. Senator, do you wish to address that question to staff? Okay, please go.
Oh, no, I'm sorry. I was thinking in terms of the conferees. Yes. My apologies. I should have used that terminology.
Well, we're a little bit ahead of time, a bit ahead of our schedule. We'll just go ahead and keep moving. Next up, we have presentation on nursing facility reimbursement rates. And first up is Sherry Gerard. Did I say that correctly? If not, please correct me.
It's Gerard.
Gerard. Okay. Welcome.
Thank you. I'm Sherry Gerard, and my title is the Director of Nursing Facility and Adult Care Home Programs with KDADS. And I'm here with Dave Halferty with Myers and Stauffer, our rate setting contractor, who will answer all kinds of questions for you guys. My part of the presentation is to kind of give you an idea of what role the state Medicaid agency that's assigned to take care of the nursing facility rates in Kansas, and that's KDADS. So I'm gonna, and then after I tell you a little bit about what KDAD's role is, Dave's gonna come up and he's really gonna help get us into the weeds of rate setting methodology here in Kansas and really help us learn exactly how that goes. And he's also going to talk about, at the end, some changes that are forthcoming. And then at the end, we included some resources to reference later if you'd like. Okay. So the role of the nursing facility program team at KDADS is to establish initial rates for brand new nursing homes. We also help establish rates when a nursing facility changes ownership. In terms of reimbursement and rate setting, we review, track, and communicate cost report submissions from the providers and from the KDAD's audit team desk reviews. We gather public feedback and make sure that public notices are posted. We update the Medicaid state plan anytime we make a change, so that happens at least annually. We apply any legislative action. We apply quality incentives and sometimes deductions to rates. Some examples would be the fiscal year 24 Medicaid add-on, the quarterly quality care assessment, which is currently $49.08 or $818 for our continuing care retirement communities, or any of our facilities that have under 46 beds or above 25,000 Medicaid bed days. We help apply the quality incentives. An example in Kansas is the PEAK program. We enforce the CMS and state Medicaid enforcement actions. That's when our state surveyors go into a facility and have a finding of a certain level, then there's a financial penalty. So then our team enforces that financial penalty. We also distribute the SPARK and the ARPA funds that were designated to the nursing facilities in the past few years. We procure and monitor the contract with our rate-setting contractor, which is currently Myers and Stauffer. And we collaborate and communicate all the reimbursement activities with them. We process retroactive and mid-period rate adjustments. This could include an amended cost report or findings from a field audit or a real and personal property fee rebasing. We manage the ventilator program. We communicate rate changes to KDHE, the MCOs, and the fiscal agent, which is currently Gainwell. And because we are a managed care state, the reimbursement of claims is handled by Gainwell and our managed care organizations, not by my team. Then my last slide is I put together a very basic timeline for you so you could just kind of see how rate processing goes throughout the year and then repeats and repeats. So in February through early May, our nursing facilities are submitting cost reports to us, and our audit team is completing desk reviews. Then April through May, a proposed rate methodology gets published, and public comment period opens, and we start taking public comment at that point. Then the end of May, rates are presented to KDHE, the MCOs, and to Gainwell, the fiscal agent. Then in early June, the final methodology for the fiscal year gets published, and I have the link there so you can go and see the current rates and the current methodology posting. And then we put together a package of information for the providers so they know the changes effective July 1st. That includes their rate schedules, their incentive calculations, and their desk review findings. Then the end of November, we make CMI rate adjustments that are going to be effective in January. Dave's going to dive deep into what CMI stands for, so in 2 seconds he'll get to that. And then we present those to KDHE, the MCOs, and Gainwell. And then in early December, the nursing facilities get that information so they know what their new rates will be effective January 1st. And then February, we start all over again. And so now I'm going to turn over to Dave to really get us into the weeds of our rate setting methodology. And I'll hang out in case anybody has any other questions. Sure.
Representative Carpenter has a question for you.
Thank you,
Sure.
Mr. Chairman. If I get too far down this, I forgot what I thought about in the very beginning. So if we could ask questions, kind of through that, it would, instead of, if she goes through this whole thing, I'm not even going to remember what I dealt with at the beginning. So if we could go back to the start. So maybe a lot of folks don't understand what the quality care is, okay? So what quality care, it's what we do for HCAP for the hospitals. The nursing homes tax themselves, and then we bring down more federal money by doing that. Correct?
Correct.
Okay. And how much is that?
What do you mean, how much
How
is
much
that?
money does that bring down, the quality care assessment?
I have no idea. Total amount that, I have no idea.
Okay.
My
Well, they-
team focuses on each facility and applying the correct tax amount. We don't get into the big.
So we have no idea how much?
I'm sure someone does, but I do not.
Okay. Brad? Oh, sorry.
Brad Ridley, Director of Operations, KDADS. I'll verify Representative Carpenter, but I believe the last year the revenue was around upper 20s, 20 million, 27, 28 million, somewhere in that ballpark. But I can verify that here in a few minutes.
Okay, very good. Thank you, Mr. Chairman. I just wanted to, I'm not sure a lot of folks understood what it does and what it is, but we've actually, it's just like the hospital HCAP program. We leverage money that the hospitals pay, tax themselves on the HCAP program, and then leverage that against federal money and bring down that. Well, this is the same thing for nursing homes. So anyway.
Very well. And we may just stop periodically as, sometimes superficial overviews like this just bring up more questions. So I also have a couple more in the queue. Senator Fagg.
Thank you, Mr. Chairman. Thank you for your presentation, Jerry.
You're welcome.
On page 2, you talked about quality incentives. And can you give me an example of a quality incentive and what it would be for and how much money, talk about that a little bit?
Sure. The one I know the most about is the PEAK program, where we encourage facilities to, what does PEAK stand for? I cannot remember what PEAK stands for. There's so many acronyms, but it's a program where we encourage nursing facilities to implement person-centered care in their facility. And the closer they are to that evidence-based practice, there's a scale, and we'll pay them more and more the higher they get. And that you can go all the way up to being a mentor home, where you're actually helping other facilities to bring person-centered care into your facility. Does that answer your question?
I got a follow-up, Mr. Chairman. Thank you. There was a couple below that. You talked about the SPARK funds. Was there any SPARK funds for capital improvements that went to some of these facilities?
It could have been. We did make payments. This is a couple of years ago, and we can get you a list of the payments we made to each facility through those Spark and ARPA dollars.
The ARPA funds were specifically for staffing support.
Was it?
So
Yeah.
they couldn't be spent on.
The most recent, they're early in COVID, there were also payments made to nursing facilities, and those were more flexible. I think the most recent Spark designated dollars were more tied to staffing.
Okay.
Senator Gossage.
Thank you very much, Mr. Chair. A couple of questions. One is regarding Representative Carpenter's statement. Did not clarify it for me. I know he knows more about this than I do, and I appreciate that. But for myself and those who might be listening, to try to understand that you've got 4,908 or 4,908 or 818, what does that mean? What is this number tied to?
That is the bed tax that is assigned, or the quality care assessment that's assigned to each facility. And Dave's going to get into that more.
We'll get into that.
Yes.
Okay. So when I heard the twice, tax of themselves, can you explain what that means?
Ask the question again. They tax themselves?
Right, it was said nursing homes tax themselves. So is it based upon this number per bed, or will Dave get into that?
Yeah, Dave's going to get into that for you.
Okay. One of the questions that I have is, as I'm looking at this, you said that there are enforcement officers that go out, there are financial penalties if people, if nursing homes are not, nursing facilities are not meeting code, et cetera. How many enforcement officers do we have in the state?
That would be a question for Lacey Hunter.
Okay. And we said at the top on page 4 that procure and monitor contract with rate-setting contractor. And they're setting rates compared to what? Is that for someone else too?
Our rate-setting contractor is who assists us with actually doing the data mining and setting each facility's rate based on the cost report.
And this is Meyer and Stauffer?
Mm-hmm.
So then we have managed the ventilator program. Is that a different contractor that does that, or is that internal?
That's internal.
That's internal. And then we have Gainwell, and they communicate rate changes to KDHE. We need someone a contractor to give these changes to KDHE, MCOs, the
My
fiscal
team
agent.
does that.
I'm sorry?
My team communicates those changes to Gainwell and to KDHE and the MCOs.
Okay. And then finally, Mr. Chair, if I may, you say that April through May, there's proposed rate methodology and it's published, and then you have public comment period. Just curious, do you ever get any comments?
Occasionally, yeah.
And it's from the public?
Uh-huh.
Okay, thank you. Thank you,
welcome.
Mr. Chair.
We have a follow-up from Representative Carpenter.
Thank you, Mr. Chair. So, and thank you for being here. So on your fines, do you have any idea how much money the fines generate every year?
No.
Could
My
somebody-
department doesn't like keep track of that. We're just there to enforce the fines, make sure they come in and apply them so that they get credit for paying the fines.
So this would be through credentialing and surveying?
We communicate with them. Yep.
Okay. Thank you.
Senator Erickson.
Thank you, Mr. Chair. Thank you, Sherry, for being here. Actually, Representative Carpenter and Senator Gossage asked two of my questions, but I do have one that they didn't address, but touched on. Can you tell me what the difference in role is between Gainwell and the MCOs? It says that they handle reimbursement of claims, but what are their unique roles? Can you help me understand the difference between what Gainwell and the MCOs do? Thank
Sure,
you.
I'll try to explain from my understanding. So the MCOs then contract with each nursing facility, and Kansas, we set the base rate. So then the MCO can then contract with each nursing facility. And then they have their own, they can have their own rate as long as it doesn't go below the base rate that the state sets. And then the claims come in, and Gainwell helps to process the claims through their software.
Okay, thank you, Mr. Chair.
Representative Haskins.
Thank you, Mr. Chair, and thank you for your presentation. And to kind of follow up on the senator's question earlier about the public feedback, and I was wondering if you could give the committee an example of some of the top issues that they give you feedback, like, we sure wish this could get fixed, or without going into too much detail, what would you like this committee to focus on today?
We haven't gotten feedback like that through public comment, but they do catch when we make errors.
Mr. Chair, one more. Well, can I follow up? Having worked for the state and knowing that there are people in your team that wake up every day to work on this, what feedback would they give us to focus on? What does your staff and team think that this is something that, man, if they could just do this?
You know, I've only been doing this job for a year and a half, so I'm not sure I have the scope to help you answer that question. There might be others to help you better answer that. I'm still just learning the acronyms.
Representative Epley.
Thank you very much, Mr. Chairman, and thank you for your presentation. And if this is going to come later, that's great, but I'm going to ask this question now, and we touched on it. On the survey process in the budget, do you have a predetermined amount of money that you try to garner each year to the budget as it relates to surveys and the fines that come from that? And the second question part relates to the survey process and the fines that result from that. Is someone going to give us a breakdown of how much money is raised through the different, because there's different tags through the fines that occur. And I don't know, maybe that's getting too far down the rabbit hole, but I'd like to know the breakdown of the fines and what the facilities are fined for and how much funds are gained from that on an annual basis. Thank you, Mr. Chairman.
We would definitely
That's
have to
something
get
that can be
back to you on
provided to
that.
us.
We can get back to you on that,
Okay, that's something that the KDADS can provide to this committee?
possibly.
Possibly. Okay.
Mr. Chair, is there a predetermined amount of money that we try to raise through the survey fine process? Or do you know, Sherry?
No, That's not how it works.
I mean, I didn't know. I didn't know if there was a end point that we've got to hit that every year for our budget. I've always wondered that, so this was my opportunity to ask, but you're not aware of that.
Ideally, we'd have no
You wouldn't raise any money
violations.
through
Our
that.
nursing homes would be wonderful.
Okay. Okay. Thank you, Mr. Chair.
Yeah.
So I've been phoning a friend on the survey side. So to answer a couple, I think the most recent question on do we have a target for amount of fines for the budget? The answer is no. It's actually the feds, CMS, that assesses the fines for nursing facilities, not the state. And we can get more information on what that looks like, but we'll have to do some follow-up on that. There was an earlier question about how many surveyors we have. We have 60 positions budgeted, but currently only 24 are filled. So we have 24 surveyors for nursing facilities today.
Representative Ousley.
Thank you, Mr. Chair. And while we were discussing the fines, if there's no predetermined amount or a quota, if you will, what happens to the funds or the fines after they're collected?
So, and I'll get more information on this, but I do know that as the federal government, CMS, assesses the fines, a portion of those do come back to the state in what's called a civil monetary penalty fund. And the feds limit how we can use those dollars. The intent is to go back to quality efforts for nursing facilities. So the intent of the dollars that do come back to the state is to go back to improve quality in nursing facilities, but those efforts have to be approved by the federal government.
Hang on a second. Representative Bryce.
Thank you, Mr. Chair. Thank you, Sherry. I had a follow-up on Senator Fagg's earlier question about incentive payments and the kind of a process question. How are the incentive programs determined? Who determines that? Is there a process for that? Is that dictated by statute? I just didn't know.
I'll go back to the one I know the most about, and that's the PEAK program. We have a contract with KSU, and there's a whole process and whole curriculum that the nursing facilities go through. There's site visit included where we go out and verify that practices are in place. Is that helping to answer your question?
Well, if I could, who determined to do that program? I guess there are several incentive programs, I assume. And is it your office that says, okay, this program, this program, this program, or is it dictated by statute? Like, is there something that we've done in the legislature that says we need to do this incentive? Just who is it that determines what we're doing for incentives, and how is that process? The determination of which incentives we're going to use. It came from somewhere.
I know some of them are in our state plan. They're all in our state plan.
Okay, thank you, Mr. Chair. That's fine.
Follow-up from Senator Gossage.
I think you can probably tell, I'll speak for myself. I'm really glad we're having this committee. There's so little that I know about how this is funded, how we oversee it, who the contractors are. I realize the more you tell us, the more questions we have. So thank you for your.
The more I learn, the more I realize I don't know. Yeah.
Same. So how many nursing facilities do we have in the state of Kansas right now?
I think there's just over 300.
300. And we have 24 enforcement officers for 300 facilities. Is that what I'm hearing? I see a head nod back there. So we talked about a site visit. How often do site visits happen per year?
That's a question for the SEC Commission.
Okay, I'll wait for that. And then maybe
Gonna phone a friend again?
and then also just to follow up with that, how many of those are known in advance or advertised, and how many of those are surprise visits? You can get that to me later, Dave, when you come up to the microphone. Thank you, Mr. Chair.
Another follow-up from Representative Carpenter.
Thank you, Mr. Chair. And Sherry, thank you for being here. So in this, you said 300, but that's only state licensed facilities, correct?
Yes.
Okay. So just to be clear, there are folks that are operating in our state that are not state licensed, and there's quite a bit more. I think there's maybe 75 more that aren't state licensed. So when we talk about, when KDAS always talks about licensed facilities, but there are more than just that many, just for clarification. And then, Mr. Chairman, can I follow up? So are we going to get into the cost report? Okay. And I know that.
Dave is going to get into the cost
Yeah,
report.
that's good.
He's going to walk you through every part of it.
Okay, very good. Thank you.
Welcome.
I think we would have done well to have Representative Carpenter as one of our conferees today.
Yeah.
I have a quick question before we move on to the next phase, unless there are other committee questions. You mentioned kind of briefly about the MCO's contract with the providers, that kind of thing. Is there uniformity in that, or is that negotiated between the providers and the MCOs? Could it vary from facility to facility what those rates are? Okay, so there's no uniformity.
It could vary. It could vary. Yes, it could vary.
Okay. Do you have a follow-up on that?
Yeah, so in managed care, and the first presenter kind of walked through it. In Kansas, we are fee-for-service. We set the floor. So the rates we set through this methodology, that's the floor the MCOs have to pay. So we set that minimum rate based on this methodology that Dave will walk through. So that managed care can pay above that, but we set the floor.
Okay. All right. So there's a base, there's a minimum.
Correct.
But then it might vary from facility to facility.
It could.
Okay. Committee, other questions before we move on?
How many MCOs do we have?
Three.
I can answer that.
Yeah. All right. Let's move on to the next phase.
Okay. Dave.
If you would identify yourself and welcome to the committee.
I'm Dave Halferty, and I work for Myers and Stauffer. We're the rate-setting contractor for the state. And I'll give you a little bit of background about myself and about my firm. Myers and Stauffer actually started in Kansas in the late 70s when Medicaid was evolving, and we took on a contract to do some work for the state of Kansas. Since then, we've evolved to a company that has 22 offices around the country and about 1,000 employees and contracts with every state in the country, as well as the federal government. So we are very deep into Medicaid reimbursement and the Medicaid program. So that's what we do. In fact, each of the states that were listed in the example that Ms. Costanza walked through are one of the states that we contract with. So we do quite a bit of work in that regard. And myself, I've worked with this program since 1999, so I think that I can probably answer most of the questions that came up, although I might have a hard time remembering what they were. I know there were quite a few. Stepping back, one, I know there was about the number of facilities. There are approximately 300 facilities that participate in the Medicaid program, but like you pointed out, there are also facilities that don't participate in Medicaid, and about 20 of those are freestanding nursing homes that just provide either Medicare services or private pay services. And then I believe there are another like 20 or maybe 40 long-term care units that are attached to hospitals that also do not participate in the Medicaid program. So there, like you said, roughly maybe 350 nursing homes around the state, but about 300 that participate in the Medicaid program. I know there were some other things. The quality care assessment was one that came up, and that is a provider tax, and that's something that's allowed under the federal rules for reimbursing Medicaid providers. So states can tax those entities that provide those Medicaid services and then use that funding to make the payments for the services that they provide. And in the process, what they're able to do is to draw down the federal match that goes with that. So in Ms. Costanza's illustration, she showed that the payment that goes to the provider or the MCO is partially federal funds and partially state funds. In Kansas, that's usually about a 60-40 split, 60% from the federal government and 40% from the state. So when we pay $1 to a provider, in state funds, that really becomes about $2.50. And so that's where that provider tax can actually generate some funding that otherwise, it'd be just a pass-through if they didn't have that kind of a match to it. So that's what that provider tax situation is about. I'm trying to remember some of the other questions that came up. The fines, again, those are, collected by the agency, and then they're used for certain things. They can be used to help improve the quality of care in different ways. The incentive programs that were developed, those are in the state plan. They are defined, they are actually developed with stakeholder input, and committees that work together to determine what things should be focused on and where should those be set. As with everything, a lot of times we borrow ideas from other states, and the main incentive program was actually borrowed from the state of Iowa when they had a program that was similar. So those things kind of get regenerated in different ways, I guess. So I'll go ahead and walk through what the goal of the slides that we put together is, to just try to give you a general overview of the reimbursement in Kansas. And so some of that was already discussed, and I'll kind of hit some highlights here. But
Hey, Dave, are you working from the same slide deck that the KDAS put
yeah,
out?
yes, it's
And
just a
please tell us
continuation.
what page you're beginning on.
6.
Thank you.
Yeah. So the first thing that we thought would be important is just to talk about some terminology, and these have already come up a little bit. You heard the word, or the acronym CMI. That stands for Case Mix Index. And that's just a numerical value that's assigned to kind of indicate what the level of care of a nursing facility resident is. In other words, how much resources are required to provide the care that they need, how much staffing, how much nursing supplies, et cetera. And in Kansas, we work on a facility average rate, so we actually gather those CMI values for each resident and average them together, and we express them out to a 4-digit value that tells us what the average case mix is for the facility. We also do that for the state. And as an example, a case mix value of 1.6000 compared to a case mix value of 0.8000 means that that first facility is caring for residents that have twice the level of needs that the second facility is caring for. So that's what that's used for. Because we know that some facilities specialize in different types of care. The level of acuity of the residents can be very different between facilities. So that helps us do that. I'm going to skip down to the second or the third one here on this slide, the resource utilization groups. So that's a system that CMS developed in the late 80s, I believe it was, and that was used to classify residents into these categories that indicate how much care they need. And again, there's a CMI value associated with each of those. So states worked with CMS to help develop that system with the intent to use it for their reimbursement system themselves. CMS developed it to use with the Medicare system. So it's got different versions that are tied to Medicare, versions that are specific to Medicaid. And like I said, for probably 40 years, it's been the state-of-the-art system and the one that Kansas has used. So the Kansas system has 34 groups in that RUG system. Again, each classification is determined by information that's taken on the assessments that are done on each resident each quarter. Each quarter, each resident is supposed to be assessed, and all their health care needs are gathered through that. And then again, there's a CMI value that's assigned to that classification that indicates roughly this is the level of care that this person needs. In 2019, CMS implemented this PDPM system, the patient-driven payment model. And when they did that, they kind of took apart what was grouped together in the RUG system. So the RUG system had allowances for therapies such as speech therapy, physical therapy, occupational therapy, non-ancillary therapy or non-therapy ancillary costs such as laboratory and radiology. All those things were grouped together in that, and then also nursing. So those things were kind of siloed differently or siloed apart under PDPM in 2019 by Medicare. Under the RUG system, they'd always been grouped together before. But again, the same idea, there's a numerical value that's assigned to each of those groups that tells you what the level of care is for that. I'll get more into that later, but that's one of the big changes that's going on in Medicaid reimbursement now is that switch to the PDPM system. So on the next slide, I'll talk a little bit about the basics of the Kansas system. And this kind of flows along with what was talked about in the first presentation. Kansas is a cost-based reimbursement system, so we're not a pricing model. So rates are determined specifically from cost for each facility. They're prospective, so we take that cost and we do apply inflation to it. So we're taking historical information and trying to project what's the future cost going to be or what's a future rate that would be appropriate for that level of care, that need. They are per diem rates, which I guess every state in the country seems to use per diem rates. They're also subject to limits. So if a facility seems to be spending at a much higher rate than other facilities, there is a limit to that. They can't just spend willy-nilly and we'll reimburse everything that they spend. The costs are separated into cost centers. So there's an operating cost center that is the admin cost. There's a cost center for indirect care, which is housekeeping, laundry, activities and things like that. And then there's also a direct care cost center that is the nursing and nursing supplies. To get to that per diem, it's total allowable cost after inflation divided by total days of care provided. And then those per diems, again, they're subject to those limits that are determined on a cost center basis. So there's a cost center for each one of those. The Kansas system is also a case mix system. And that case mix, again, is the idea that you're going to look at what's the average acuity of all the residents in the facility, and how does that compare to other facilities? How does it compare to this facility previously? And then you're going to make adjustments to the rates, to the cost data and to the rates to reflect that. And the first thing that we do is we call it neutralization. We're going to try to move everybody to what their cost would be at a standard case mix. So we look at the state average and we adjust those costs to match the state average. And what that lets us do is, because we want to set a limit, we want to be able to look at everybody on a level playing field. So what does facility A spend to take care of this level of care? And what does facility B do to take care of that same level of care? And then that way, when we impose a limit, we're doing it equitably, rather than just saying, well, we're going to have one limit, and facility A, just because they cared for really heavy care residents, they're going to get hit by that limit. That wouldn't really be fair. So that's why we do that process. So that's the first thing we do with case mix. The second thing we do is we try to adjust the rate to match what the Medicaid acuity is. So we know in a facility, you've got Medicare residents, in most facilities that is, Medicare residents that are generally really high acute. They're going through rehab. They're at a much different picture than the general Medicaid resident that's longer term usually and generally stabilized, but still has great needs, of course. And then, of course, there's also private pay individuals. So we're trying to use that case mix system to adjust the rate to reflect the acuity of the Medicaid people that the state is paying for. After that, there are some add-ons to the rate, and those add-ons include the real and personal property fee, and we call that an add-on because it's not based on the current cost of ownership that the facility incurs. It's based on previous ownership costs that were inflated, and then any adjustments that might be made to that to reflect new capital expenditures. So if they put a roof on the building or something like that, that gives them a chance to increase that. There's also these incentive payments, and those are pay for performance. They look at different outcomes. One of the biggest ones is quality measures. And those quality measures are indicators of the level of performance the facility has provided. There's also some that are tied to staffing, so the number of hours of care that the facility provides per resident per day, that goes into that calculation. And then the one that Sherry alluded to quite a bit, the PEAK program, actually is kind of a pay-for-performance program that tries to encourage facilities to be more person-centered and provide care that's more person-centered. Facilities can begin that program just by doing some educational efforts and some self-evaluation efforts. And then they move throughout that program by accomplishing, setting a task plan to accomplish, an improvement in that area. And then eventually they can work up to a level where they actually become a mentor to other facilities. And so that's what that PEAK program does. The bed tax adjustment is another pass-through, and this tries to pass through the Medicaid share of the cost of that provider tax that I brought up earlier. So that's a per diem amount that's calculated. This would fall into that category of directed payments. So one of the questions that came up earlier was, where does Kansas fall in that one spectrum? Is Kansas a state that requires a minimum nursing facility payment? And we do require MCOs to make that minimum payment, whatever the calculated Medicaid rate is for that facility becomes that minimum. And then it also does contain a directed payment where that provider tax adjustment gets added on to the rate, whatever that amount comes out to. And then finally, this year, there is this Medicaid add-on that is another extension of those provider relief funds that were distributed to providers. So then moving on from there.
Dave, excuse me, Dave.
Yeah.
Can we break here and have some questions?
Yes.
Okay, thank you. I have one from Senator Gossage.
Thank you, Mr. Chair. You have mentioned the MCOs. How many, we have 3 MCOs, is that right? Or
I
more?
believe that's correct, that there are 3.
And the names of those?
I'm not directly
Somebody
working
else?
with that right now, I'm sorry.
Okay. Do you know what percentage of the patients that are dual eligibles that are in our nursing facilities today?
She said that the nationwide statistics were 84%. I think it probably very similar in Kansas, but I don't know the exact number.
Okay. And then you mentioned pay for performance, the PEAK efforts. I'm assuming those are measurable goals. They set these goals. If they meet these goals,
Right.
they get a certain incentive.
Right.
Is that right?
Both of the incentives are tied to measurable objectives. Again, with the base incentive, what's just called the incentive factor, it's staffing ratio. So if they have a high staffing ratio, if they meet a certain threshold that's set at the 75th percentile, then they get an add-on for that. If they fail to meet that threshold, but they show that they've improved significantly from the last year, then they can also get an add-on for that, but it's lesser. Besides staffing ratio, staff retention is another one. There have been many studies that have also tied staffing ratios and staff retention to quality outcomes. So those things are used. Let's see, there's also one tied to quality measures. And again, those things are determined from the assessments that are conducted on each resident. So the health assessments that are conducted for each of the residents. In aggregate, we look at the statistics for each facility, and if they're excelling, I think there's 8 different ones that contribute to that, such as, the use of anti-psych medications, let's see, mobility, falls, there's several different things. Those all get plugged in, and then again, if they meet a certain criteria, they can earn that add-on. With the PEAK program, that program stands for Promoting Excellent Alternatives in Kansas, and it was the idea that nursing facilities had really become medical institutions, but people go and live there for many years in some cases. And so there was an effort to try to make nursing homes more person-centered, and that began in the late 90s. And Kansas actually got involved with that probably in the early 2000s, 2001 or 2002. And at first, for about 10 years, that program just recognized those homes that were doing significant things. So we asked facilities to actually submit applications to be awarded or be recognized for their efforts in that regard. And there was, a set criteria that fell into. For 10 years, we probably recognized a total of 30 facilities and had maybe 50 facilities that had applied for that program. Once again, you've got 300 facilities, so you had 1/6 of the providers that were really taking that to heart and trying to pursue that. So in 2013 or 2012, we revamped that program and created this, really it's a quality improvement process that the first idea was just do an assessment of your facility. And we developed an assessment tool that they could use to evaluate themselves and determine whether or not they were person-centered or not, if they were hitting on these checkpoints. And we worked with the task force of nursing facilities that had been recognized through that program and borrowed information from other states and identified like 12 core areas, such as, do they force people to get up at the same time every morning, or do they allow for individual differences? Do they promote choice in terms of, dining and like that? Do they give options? Do they empower their staff to be able to do things? So there's all those things were worked out. Like I said, 12 core ideas were developed, and they would assess themselves on those 12 ideas. If they did that alone, they could get an entry level per diem added to their rate. If they went beyond that and showed that they were willing to develop a work plan to improve whatever area they found they were deficient in, then they could move up a step and actually get an additional reimbursement for that. If they made it to where it looked like, or they showed that they were hitting on all 12 of those core competencies, then we would send out a team of volunteers to go and review that and verify that, yes, they are, and they would earn a different per diem. If they moved beyond that and they started to help other facilities by inviting them in and mentoring them, then they could move beyond that and get an additional per diem. So that's what that program does. It's trying to promote, again, person-centered care through that tiered reimbursement.
Thank you for that thorough answer. That's very helpful. The definition of the nursing facilities, does that include assisted living?
It does not.
It does not.
No.
And then the state plan that you mentioned, who approves that?
CMS, the Centers for Medicare and Medicaid Services. So every state has a Medicaid program. Every state has to maintain a Medicaid state plan that outlines what services will be provided and how they will be reimbursed. And so, as Ms. Costanza alluded to, there are certain things that are called entitlements. Nursing facility services are required. If you have a Medicaid program, you have to have a nursing facility program.
Thank you. And finally, Mr. Chair, so it seems that there could be a reverse incentive for, if I own a nursing facility, to want my patients to appear to need as many services as possible so that I could get a higher reimbursement. Not to say this happens, just say it could happen. So who oversees and looks to see, are these patients really, is this accurate about these patients?
Right. That is a good point, that there is an incentive there to make sure you're capturing all the care that you're providing so that it looks or is reflected in the rate that you get paid. So the health survey team that was talked about before, when they go in to review what the nursing facility is doing, one of the things that they look at is the medical record, and does the medical record support the assessment that they completed on the individual. So if they indicate that this person's getting this type of treatment, then it's got to be supported by the medical record that shows that they were diagnosed with what needed that treatment. So there's that level of effort. There's also some, what I call kind of a natural check and balance in the system, because again, and I'll get into the details of this, but with what we're doing, we're always looking at historical information and then trying to project what's the future cost going to be. And what we do when we calculate that for direct care, we determine what is the average level of care that they provided during this period. Well, if they're inflating that, then that's going to make their per diem less because they've inflated that. So on this side, when they're getting the payment, that's where the incentive that you noted is, make my Medicaid acuity look as high as it can be so that I get a bigger payment. But when you do that, then you're also overstating what you did that's going to become the next base that we look at to determine, okay, what do they spend to take care of this level of care? So in that regard, I call it just kind of a natural check and balance because, yes, at first you might benefit from overstating that, but on the back end, in the future, you're going to hurt yourself because you've overstated that.
Thank you, Mr. Chair. Thank you very much.
Sure.
We have a few more questions in the queue. Representative Carpenter.
Thank you, Mr. Chair. Dave, thank you for being here. I need your personal information so I can get a hold of you. This guy's got a ton of information that I'd like to hear. So you talked a little bit about the cost report. So what percentage of the cost report would you say that the payments would be for a nursing home? How much would that affect it?
So the entire calculation is based on those costs. So it affects the entire calculation because we do have some limits that are set. One of the things that we look at, and those limits impede some facilities that seem to be spending much higher than others. So they may get limited to a calculation that's less than what their cost is with inflation. Because of that, we look at a statistic is called cost coverage. We take, okay, this is what their costs were with inflation to push it out to the rate period. This is what the rate calculated out to, and how did the two compare? Generally, the cost coverage in Kansas is in the 90%, so 95, 92 to 95% overall. And then for direct care, we also look at that same statistic, and it's usually above 95% for direct care.
Okay.
So it's very driven that way. There is not really a margin for profit in the Medicaid payment. It's really cost.
Well, and may I continue, Mr. Chairman? So this includes utility bills, property taxes, you know, the whole expense of operating that business. Okay.
Yeah.
So then we are manually entering this information? The state does?
Right. So the information comes in on an Excel report from the facilities. And then we use programs to pull that data across and analyze it. Each year, each one of those cost reports gets reviewed by a team of auditors. And one of the things they do is they look at previous data and did they have a big change in a particular area or not. And so that helps them focus on these are the things that we need to ask for additional information about and review that. If they see things that really look out of line, then they do full-blown audits of those where they do a much more detailed look at it.
Okay. And following up on that, so you operate in other states. How many other states operate manually like we do versus a computer program that they can fill out the information on the cost report and send that to you by computer or by Excel or whatever?
Well, again, we do use Excel. Yeah,
I know, but I'm just saying, I'm talking about the nursing home operators. Fill this massive piece of paper out.
Right. I'd say for the most part, most states use the federal cost report, the Medicare cost report.
And I was going to get to that.
And then they supplement that with their own data that they may collect on a separate schedule. Kansas still uses a state-specific cost report, and I don't know the exact figures. We actually work with probably 35 states on nursing home reimbursement of some sort, so I can probably figure that that out, but I do not know, like, 50% of them.
I'm just curious if we're like in the Stone Age compared to other states by
I
manually.
I don't believe that
Okay.
I would say we're in the Stone Age.
So-
In fact, our Excel cost report, even though it's dated, it looks much better than some of the ones that I've seen, so.
Okay. And then finally, how many states use the Medicare reimbursement?
So most states, I don't believe any state uses the Medicare per diem, the Medicare reimbursement. Again, it's kind of geared differently. It's going to pay for therapy and those ancillary lab and radiology things that Medicaid wouldn't normally pay for. What we use is the Medicare cost report. So the Medicare cost report is still going to capture, this is what you paid your nurses and how many days of care you provided and all of that. So we can still get to a per diem there. So I would say that probably of the 35 we work with, maybe 15 use that Medicare cost report as a beginning, and then they also have a supplemental report that they require providers to do.
So they don't use a state report like we do?
Not a state-only report.
Okay.
They do have a separate report that they're collecting some information on, but then they blend the two together.
Blend the two together, but they do have a state report then?
They do,
Okay.
yes. I don't believe there's a state that solely relies on the Medicare cost data.
Okay. And then finally, at some point in time, could you get us a slide of the RUG, just so folks could understand how complicated that is?
Mm-hmm. Yes.
Okay, very good. Thank you, Mr. Chairman.
Senator Fagg.
Thank you, Mr. Chairman, and Dave, thank you for your presentation.
Sure.
A couple of these are kind of one-on-one, but how many clients do we have in facilities in Kansas? And have we looked at what kind of trending is there, and did COVID affect that? I wonder if you'd talk a little bit on that.
Yeah, and I do not have the exact numbers. I know that Medicaid census has generally hovered around 10,000 per month. So at any given month, there's generally, I think, about 10,000 Medicaid residents that are being paid for, out of the total of probably around 17,000 total nursing home residents on, again, a monthly basis. So Medicaid's more than half, but not quite 2/3, maybe.
Follow-up question, Mr. Chairman. On your CMI, how often is that adjusted?
Yeah, so the facilities are required to do those assessments on individuals every quarter. Every 92 days, I believe, is the federal rule. And so we gather that information each quarter and update it. The rates get updated each 6 months, every 6 months. So we take 2 quarters of data at a time and then average that together to do that adjustment. So that way, we make an adjustment to reflect, okay, that nursing home's Medicaid acuity went down. So we're going to move their rate down to reflect that. Or it went up, and we're going to move the rate up to reflect that.
Mr. Chairman, one final. Dave, this is kind of I've always wondered this, but when you walk down the hall of a nursing home, and you know one guy's a private pay and one is paid by Medicaid, is the actual rate the same on both of them? The state's just paying the one? Is everybody paying the same in the hallway, or how does that work?
No, it's not.
Okay.
The private pay individual negotiates a separate rate with the nursing facility that they're paying. Medicaid, again, we set rates for the facility for the fee-for-service side of the Medicaid program, and then the MCOs are required to pay that rate as a minimum. So the MCO may negotiate with the nursing home too, and they've got to pay that Medicaid rate as a minimum, but they may, in some cases, I think, pay more than that minimum rate, especially if they find that they have a hard time placing somebody that's really got some significant needs. So again, the case mix system is supposed to adjust for that, but it's looking at the facility-wide situation. So even the MCO might negotiate different rates with the nursing facility for different residents, depending on the level of care and their difficulty in getting them placed. But the general idea is, again, we look at the Medicaid acuity and develop a rate that reflects that. Private pay individuals would be negotiating their own rate. And then Medicare, of course, is going to be paying a rate based on its system that takes into account different things than what Medicaid pays.
Thank you.
Representative Epley.
Thank you, Chairman Less. And again, Dave, we appreciate you being here. And this may seem like a pretty basic question, but I know that facilities, at least even in my own community, there's some facilities that are designated skilled facilities and those that aren't. And I know that's primarily CMS driven, I think almost entirely.
Yeah.
That doesn't have any, does that have any impact on the data that you presented here? Because that's all about Medicaid. And I just wondered if you could talk about that, because that's a big deal to these facilities that they can get skilled designation. And then, of course, for the hospitals, it's swing bed. And, you know, you just, there's so many designations that are attached to so many different factors as it relates to reimbursement. Could you talk about that to, and maybe the committee already understands all that, but I think it's confusing, particularly to providers and I think to common folks. Thank you.
Right. So when I hear the word skilled nursing facility versus nursing facility, I'm thinking Medicare versus Medicaid. So they can participate in both programs, but if they're going to participate in Medicare, then they've got to be licensed as a skilled nursing facility. And that just enables them to provide Medicare services and get paid for that from the federal government. And generally, again, Medicare residents are there on a rehab stay. They've had to have been in a hospital and qualify for that care. That care is really limited. It's intended that they're going to rehab in 20 to 100 days, and then they're out. Yeah, they're going back to whatever, their home or an assisted living or something like that, right? So that's a lot higher reimbursement, and that's why nursing facilities talk about, well, that's beneficial to me, because if I can provide those services, I'm going to get paid at that higher rate. And there probably is maybe a little more profit margin in there. The Medicare system does not simply rely on cost. It looks at cost, but it develops a rate that's really not driven by the individual facility's cost. So there might be some profit more there than there is elsewhere. And again, Medicaid, the idea there is that it's going to pay at the last resort, right? It's going to step in when all other resources have been exhausted. So that's kind of the difference between the two. So there is that incentive. You also mentioned swing beds. So hospitals can participate in the swing bed program, which means that they can take a bed and make it basically a nursing facility bed if they would like, when they need to. But they can also use that bed for hospital services if they're not using it for nursing facility services. When they participate in the swing bed program, because they're usually providing very few days of nursing facility care, we try to simplify things for them, and the state created the swing bed payment program that bases that payment rate, that per diem rate, on a survey of all the rates in the state for nursing facility services. And basically it just gives the hospital the opportunity to say, okay, I'm going to use this bed in that way so I can provide nursing home services when I need to, but I don't have to go through the effort to put a cost report together and submit that and go through the rate setting process. I'll just agree to take this rate when that happens.
Yeah, thanks, Mr. Chair, for the liberty. Just one more question back to skilled. There are patients, and I want folks to understand this, that are getting services both from Medicaid and from Medicare. You know, depends on their complexion. I mean, there are a lot of pure Medicare and pure Medicaid patients, but there's a lot of, most of them have both services in my experience. And so if you're on a swing bed in a nursing home getting those services, higher reimbursement, does that impact the data that you obtain as it relates to Medicaid services, because they're getting reimbursed by CMS for those skilled services? And I know that's a little complicated, but can you talk about that? Thank you.
Right, yeah, so that's actually the case for any facility that participates in Medicare. They're going to have those higher costs associated with caring for those individuals. So I think where you're maybe going is that could kind of skew the cost that we get from that facility because, well, they cared for those high acuity people. That's where that case mix system comes in. We take that value, that index that says, well, you provided a lot of Medicare services. You've got a high case mix because of that. And that's going to be used to adjust the per diem rate that we get for that individual facility so that we put everybody on a level playing field. So we get facility A that had that case mix of 1.60 that I talked about, and facility B that was at 0.8, and they each have their own cost. Hopefully they're somewhat related, right? You know, this guy should be spending twice as much as this one. But we're going to adjust that, and we're going to move that to, okay, what's the cost at, say, case mix of 1.0 for both facilities? So we can do that. It's just a proportional calculation. And now we can compare all 300 nursing homes that participate in the Medicaid program, and we can do it at this level and determine, okay, this guy's exceeding a lot, and he needs to be held to a limit. And the rest of these, maybe they're in line. They're not spending absorbently beyond what the others are, and so we'll allow their cost. So that's where case mix comes in. That's the first thing that we do, and we call that neutralization. We're going to neutralize the cost so we can compare it and make an even comparison, a fair comparison. Yes.
We'll take a question or two from Representative Haskins, and then we'll allow you to move on.
Sure.
Thank you, Mr. Chair. And again, appreciate it. And since we're asking these questions on these slides, I just wanted to jump in on this. And I want to go back to the case mix index here. And my understanding that this is a self-reported assessment by the nursing homes, then it's to keep accountable evaluators going, and there's a check and balance. Is that correct?
Yes.
Okay, and then on the page 7, you talk about, before I go, is that a state determined, this case mix index? Is that something that we created, or is it that's part of our plan, or is it something that the federal government has established? Or?
Yeah, and it was developed on the federal level with states participating in that development. Kansas was actually one of the states in the early 90s that participated in that program to develop that. And then there have been adjustments, again, because Medicare reimburses for therapy and such, there's actually a version of it that's more specific to Medicare, and then there are versions that are more specific to Medicaid.
Sure. And are there any benchmarks in which these index are measured against? I mean, can someone score in a 0? I mean, 0, 0, 0, or can they be a 5? I don't know what this assessment was.
Right, yeah, so the CMI values that get assigned, under the RUG system, they range from, I think the lowest is 0.59, which would indicate, you know, and it's titled reduced physical function, so somebody that just has mobility issues, right? 2 as high as, say, a 2.23, I think, is 2.42 maybe is the highest level. So again, 0.59 versus 2.4, that's roughly 4 times the level of care, right?
Yeah, and that makes sense. I just want to make sure that there is a playing field for those.
Yeah.
And my final question on that, Mr. Chair, is on page 7, you give us an illustration, if you will, of how this case mix system is used to neutralize the direct care costs. And then it was mentioned that there's an adjustment for inflation. Did I understand that correctly? And that inflation, when it comes to that consumer price index, are you looking at the state, the region, the nation, or the city? And then my other question is, why aren't we using, or are we using cost of living measurements for that? Because it seems like that would be more relevant.
Right, so we do use a market basket index that's specific to nursing facilities.
Okay.
And it's one that CMS developed, that the federal government developed for their Medicare system. It does have adjustments within it that reflect state wage index, so there's an adjustment for that that allows you to convert that to a Kansas-specific value. Again, it's specific to nursing homes. It's very similar to the consumer price index, but it's specific to nursing home care.
Thank you very much.
Sure.
Okay, committee, before we move on, I want to tell you what the 3 Kansas MCOs were currently, if you want to jot them down. It's Sunflower Health, Aetna, and United Healthcare. And I say currently because the state's in the process of relooking at that. So Dave, you were ready for page 8, as I recall, right?
Yeah.
Please proceed.
I'm gonna try and roll through maybe another 10 slides here, and then I'll just stop and answer some questions as we get into more specifics. But the next 10 slides kind of try to give you a general idea of what we do to set a rate for a nursing home. So in general, we're going to take their cost that they reported to us. We're going to apply inflation to that cost after it's been reviewed by the auditors. So if there's any adjustments, those get backed out. Then after we've determined what those inflated costs are, we're going to divide that by total days of care that were provided. And that gets us to a per diem cost. And then we're going to subject that to limits. So one thing that's a little different about the Kansas system is rather than just looking at 1 year worth of cost data, we look at 3 years worth of cost data. And that was actually a legislative directive that required that. So the trade associations, I believe, got the ear of a legislator, and that was proposed, and that actually became a statute. So 3 years worth of cost data. All of it gets inflated, but different inflation factors for each year. Then it's divided by days to determine a per diem, and then that's compared to other facilities to determine, is it an outlier or is it reasonable? And then that's how the rate is based. So that's the general idea. So to document that effort to calculate that, we send facilities, the department sends facilities, a rate schedule. And I believe you got a copy of this. I hope you did. There's a picture of it on slide 9 that shows what it looks like. That rate schedule includes several different areas. It's got just some basic provider information. It's got some cost report statistics. And then it's got sections for the rate calculation that are divided into each of the cost centers. There's one for operating costs, which again, that's admin cost. There's one for indirect care, which is room and board, housekeeping. And then there's also direct care, which is nursing and nursing supplies. There's also a section for the real and personal property fee, which is paid in lieu of ownership cost. And then at the bottom of the rate schedule, there's just some sums and these add-ons that we pay that are not based on current ownership cost or current provider cost. So hopefully you've got that rate schedule. The indirect healthcare section of that is the most straightforward section. It's got fewer unique rules that apply to it because there are some unique rules that apply to each of the cost centers differently. So walking through that indirect healthcare cost center, you can see if you find that, it's right in the middle of the page. Essentially, it's the 4th section down, if you found your way there. The top line, again, is the total cost that came in on the cost report. And we've got 3 columns, one for 2020, one for 2021, and one for 2022. In Kansas, providers have to file a calendar year cost report. They complete that for January through December. They submit it by the end of February. It goes through a desk review process at the state. And then, again, it can be audited if they find issues that concern them. But by the end of April or early May, that's settled. And we have what generally is final cost that we use for this calculation. They are subject, to future audits. They can, if something triggers some review, that can happen, and that can trigger an adjustment later. But for the most part, that gets done during that 3-month period between February and May. So that second line on that schedule in that area, that shows you what those adjustments are. And those adjustments might mean things that, well, they have an assisted living facility too, and they didn't split the cost up between the two like they should have. So there might be an adjustment for that. Or maybe they reported some cost in direct care that really should have been in indirect care. So you'll see adjustments, both plus and minus. Generally, they correspond. So one will take it away one area and add it to in another area. The next 2 lines show you what the total adjusted cost, so just adding or subtracting whatever adjustment the auditor made, and then applying inflation to that. And so there's an inflation factor that we determine from that indice, that index that we talked about. It's called the Nursing Facility Market Basket Index. And it's just like the CPI. We have an index for the midpoint of their cost report period, June 30 of whatever year we're looking at, to the midpoint of the rate period that we're setting, which is on the state fiscal year, so December 31st. And we look at those two and determine what is the rate of inflation. So that index tells us historical values, but it also tells us projected values. And we use that to try to calculate, okay, what is the future cost going to be for this facility? Then when you get to line 5 and 6 in that section, you're going to total up the total cost because we have costs from 3 years. Each one got inflated. Each one got different inflation factors to match it to that rate period. So the total that we get there reflects, okay, this is what we think their projected cost would be during that rate period. And then we're going to divide that by days of care to determine what the per diem amount would be. So that's, again, we've got days for each year. Those days are subject to an occupancy rule, so a minimum occupancy of 85% is required for most expenses. If they have a fixed expense, of course, and you're dividing it by days, if they've got few days, that cost is going to look really large and maybe exaggerated because of that. So the 85% rule ensures that there's some sort of efficiency required, that even if they have low occupancy, those fixed costs are going to be divided by a number of days that would be reasonable to expect them to provide. Again, it's 85% of what their total capacity would be, so just their beds times number of days in the year. The next slide is number 14, and what we're looking at there is a comparison of the per diem rate that we calculated for each facility and determining what the median is. So we've calculated those per diems for each facility. Now we're going to determine what's the median, and that's going to be the basis of the limit that we set. For indirect health care, we add 15% to that median. So in theory, that median's the middle cost across the state. If we add a percentage to that, then that really does mean that every facility has an opportunity to meet that limit, to come in below that limit. Again, it's the median plus 15% for indirect care. So if everyone in the state has relatively similar cost for indirect care, they should get their cost. If they exceed that limit, though, then they'll get held to the limit. So that's the last thing that you see in that section, is either they get what their per diem calculated to or the limit. So in this case, it's $57.99 is what they actually get paid. The limit was $68.78, and so they're going to get their cost rather than the limit. So that's a cost center limit idea again, and again, trying to ensure that the state's not just paying, becoming a pass-through, essentially, that there's some rationale or some level of efficiency required for the facilities. And that comparison is looking at all the facilities in the state, determining that median and then adding to that. Those limits get adjusted the closer we get to the direct care cost. So indirect care, you add 15% to the median. For operating cost, the admin cost, we only add 10% to the median. And then for direct care, we add 30% to that. So there's those three cost centers again. The closer we get to the resident-specific cost, the greater the tolerance is for those outliers. So then on slide 15, I kind of noted that again, that there's that 15% add-on that determines what the limit is. And for indirect care, that's $68.78. And then also there's this 85% rule that, again, we apply to determine whether or not that facility should be held up to a divisor that's greater than their actual days of care that they provided. So it's kind of an efficiency factor. That doesn't get applied to everything. It doesn't get applied to direct care, and it doesn't get applied to things like utilities and food. Those things, again, are pretty well tied to the resident, and you don't want them to cut those things, so that's why those are exempt from that. On slide 16, I just have a summary of the operating cost center. So again, this is the admin cost that the facility incurs and the plant operating expenses that they incur. And again, we use the same idea, cost divided by days. Inflation's been implied. We look at all the per diems in the state, determine what's the middle, add a percentage to that. Only this time we only add 10% to that. So it's a little tighter tolerance for outliers is what I would call them. So 110% of the median. There's also a limit in this cost center for owner administrator compensation. So a facility just can't come in and say, I'm going to be the administrator, I'm going to pay myself $300,000 and blow it away, right? There's a limit on that. And there's actually limits that apply in each of the cost centers. Say maybe the owner is the director of nursing. They can pay themselves a good salary, but that salary is limited to the state civil service salary schedule. So there's a limit there. If they happen to exceed that amount, then that amount can be brought over to this administration cost center, and that's where it's limited to that owner administrator total limit that gets applied to that. So there's again, some limits applied to things so that they just can't create exorbitant expenditures for things. On slide 17, I go through the direct healthcare system. And the direct healthcare component has some more complicated rules. I talked about case mix adjustment. This is where we do that. So we do two things. We try to neutralize costs before we compare them to each other. So every facility in the state has a different level of care of the residents that they're taking care of. We want to make sure we account for that before we compare things. We also do a Medicaid acuity adjustment to make sure that we adjust the rate that we're going to pay them to reflect the Medicaid acuity for the current period. So there's those two things. And then again, with the limit, we're more tolerant of those outliers with direct care because this is nursing and nursing supplies. It's very much driven by the residents and the level of care that they need. So that's why the limit's set at 130% of the median. So same ideas again, cost divided by days, inflation's been applied, compare them to all the other facilities in the state, find the median and add a percent to it, and then that becomes the limit. So either they get their cost or the limit, whichever comes out less. On slide 18, I tried to address this idea of neutralizing the cost. So again, I've got total cost for each facility for each year. And in this case, this facility had almost $1.8 million in total cost after inflation. I want to adjust that to match what the statewide average case mix is. So I'm going to look at their case mix data and determine what was their acuity for that period that they reported, that cost report period, and then what is the statewide acuity for that same period. And I'm going to adjust their cost up or down to match whatever that state acuity is. So on the next slide, if you look at that, for 2020, we've circled the facility cost report period CMI and the statewide average CMI. And those values that I kind of alluded to before, talked about 1.6, 0.8. This facility, their case mix, their average case mix for the cost report period was 1.0041, compared to the state average, 1.0706. So the state average acuity was a little bit more than what their average acuity was. That's what those two numbers tell me. And then I want to use that to adjust their cost so that it reflects the state average, and then I can compare it to the other facilities in the state. So if you go back to the slide before that, that's how the 1.79 million becomes 1.917 million, because I knew that the statewide average case mix was more than what their average case mix was. So I want to bump that cost up so that it's equal to what it would be if they were caring for the statewide average case mix. And then that lets me compare them to all the other facilities in the state so that I can determine what's the median, what's the cost center limit going to be. Hopefully that made sense. That's that idea of neutralizing the cost. I'm moving everybody to the state average so that I can make that comparison and make it on a level playing field. If I don't do that, then the guy that has really high acuity probably has really high cost. He's going to get limited more than the facility that has lower cost because they have low acuity, and I haven't compensated or haven't accounted for that in the process at all. So that's the reason that we do that first step with case mix. And that lets us then determine what's the limit for the state, and how do they compare to that limit in the state. Then the next thing that we do is on slide 20, where we do the Medicaid acuity adjustment. And what we're trying to do here is adjust the payment rate that we've determined, what we've determined as their allowable amount, so that it matches the Medicaid acuity. And it's the same type of comparison, except this time what we're doing is we're looking at the Medicaid residents only for the most current period that we have data available for, and we're determining what's the acuity for those people, and how does that compare to that statewide average that we already made all the adjustments for. So that's what's circled at the bottom, and we even have the formula included in the rate schedule so that it helps providers look through that and check that calculation. And also they can take future information. So they get this every 6 months. During that time, they can also track what their case mix is, if it's changing, and they can project what their future rate's going to be by just plugging numbers into that formula. So on page 21, on slide 21, we've circled the Medicaid CMI information. Again, those assessments are done every quarter on the residents, and each assessment gets classified into a specific care category, and then those categories have case mix indices that are assigned to them that indicate the level of care that they have. These values that are listed here are the averages for the Medicaid residents for each of those quarters. And so since we adjust the rates every 6 months, we're looking at 2 quarters at a time. The July 1 calculation uses the first and the second quarter. That gives the facilities time to complete those assessments, submit them. They get reviewed. If there's issues with things, they get a listing back from us that says this is what we've identified as the payer source and case mix value for each of these people. If they have concerns about that, they can change or update or correct those things. So that process goes on, and then they're used to set the rate for July 1. So that first and second quarter gets used for July 1. The third and fourth quarters get used for January 1. And that average that we calculate, it's just a simple average between those two. That then gets compared to that statewide average that we used when we neutralized everything, because that process of neutralizing all the data before, that adjusted everything so that it's all associated with that statewide average that's circled on the next section. So again, there's 2 things that happen with case mix in our system. 1, we neutralize costs so we make fair comparisons to determine a limit. And then 2, we adjust the Medicaid component, the direct care component, for the Medicaid acuity so that the payment reflects the Medicaid residents that they're caring for. So I know that was complicated on the direct care part. I'll just pause there and see if there's any questions that brought up.
Let's find out. Committee questions? Senator Gossage.
Thank you very much for walking us through this, and your slides are excellent, even though I'm struggling to follow, but I think I'm there. You know, you mentioned earlier when you were answering Representative Epley's question about reduction for services paid by Medicare. So you said that is followed into the CMI. I don't see where that's calculated in.
Right. Okay. So that facility average CMI that was back on slide 19.
Slide 19.
Slide 19, we identified 2 things there. There's a facility cost report period CMI and a statewide average CMI. That facility cost report period CMI, that's going to reflect those Medicare individuals. So if you just carved out the Medicaid only, it probably would be lower because the Medicare is usually a higher level of care. So that's how that happens, is that's the base, and then we adjust that to match the Medicaid acuity for the payment. So again, that's one reflects the total residents, and that's where Medicare is captured. The Medicaid payment, though, only reflects the Medicaid acuity, and that's how you differentiate between the two.
So would there be a subtraction or no?
The proportional calculations will take care of it. It's not like that we identify there's $10 that needs to come off. It's that proportional adjustment that gets done that makes that. So
they're not receiving double payment in other
right,
words.
they're not receiving double payment in that way, no.
Great. And my last question, Mr. Chair, is it says on slide 22, real and personal property fee, and the ownership costs in 1985. Can you tell me why we're using that?
Yep, and that's actually the next place to go is the real and personal property fee. So,
Okay.
so that was developed as payment for ownership costs or leasehold expense in lieu of actually looking at what their current ownership costs are. And that came out of concerns over changes of ownership that were driving cost higher and higher and higher without providing any real benefit. So every time a building sells and somebody goes and refinances it, there's more cost associated with that. And so at that time, it was such a problem. I mean, I've heard atrocious stories where this provider and this provider got together and said, okay, I'm going to sell you my building and you sell me yours, and I'm going to get more money because we're going to drive that rate higher. That's the worst case scenario that we heard. But it was an issue for both Medicare and Medicaid at the time. And so that's why they came up with this idea that we're going to determine what is your ownership cost now. We're going to lock that in. And in theory, if you own the building for a long time, your ownership cost will come down, and that per diem will cover more than your ownership cost. It will actually provide a profit margin. So the idea was to encourage long-term ownership of the facility. So that's why it was created and locked in 1985. Now, obviously, you wouldn't expect a facility to never do anything to the building between 1985 and now. So that's why there's an opportunity for them to rebase that. And so if they have expenditures during the year, they can submit those expenditures, say for a roof. I think I mentioned that earlier as an example. If they put a new roof on the building, they can submit that. That gets run through the calculations to determine what's a fair per diem, considering the amortization of that, the depreciation of that expense. And then it gets added on to that real and personal property fee that was already calculated. So,
Thank you.
So that's why it's locked in like that. Again, it was an issue for both Medicare and Medicaid that changes of ownership were just simply driving cost higher and higher, and that's why it was done.
Thank you, Mr. Chair.
Committee, further questions before we proceed? Seeing none, please proceed, Dave.
So one last thing on the real and personal property fee, there is a limit set on that too. So we do compare those to the other facilities in the state. That limit's even tighter than the others. It's 105% of the median. Okay, the last part of the rate schedule, clear at the bottom, and it's shown on slide 23. This just sums up all of the calculations that we've done before, and then also includes some add-ons that are paid to the facilities for different things that aren't determined specifically by the ownership or the cost that were reported on the cost report. So the first line there just totals up all those cost centers that we talked about before. You've got operating, indirect care, direct care, and the real and personal property fee. And then we have these add-ons, the incentive factor. And the incentive factor, again, it's based on performance measures that we can assess for each facility. So how many hours of care did they provide for each resident that they cared for? So we look at that. If they are at the top end of that, then they can get an add-on for that. There's also one for staff retention. If they retain staff from year to year more, that's been tied to high-quality care through studies. There's also an add-on for that. If they have exceptional performance on these quality measures that are derived from that assessment data that's collected on each resident, then they can also earn an add-on for that. And then finally, there is one that's tied to Medicaid percent. So if they have a really high level of Medicaid utilization, they care for more Medicaid individuals than most facilities, then they get an add-on for that as well. So that's the incentive factor. Then there's this Peak 2.0 incentive that we talked through, that quality improvement process. They can earn different add-ons for that. There's a bed tax adjustment, which kind of falls into that category of a directed payment that was mentioned earlier. What we're looking at there is, rather than looking at their historical cost for the provider tax, we look at what's their projected cost for the upcoming period, because that tax can change from time to time based on the number of beds that they have that are licensed, and also whether or not they fall into a category called continuing care retirement communities, or whether they are really high Medicaid. They can get a lower tax rate for that. I think someone noted earlier that in Sherry's slides there was a tax rate of $818 and a tax rate of $4,908. The $4,908 is the base tax rate that's assessed to all facilities, but facilities can qualify for a lower tax rate if they fall into one of those spatial categories: high Medicaid, CCRCs, or small facilities. Small facilities are defined, I think, as 46 beds or less, or maybe it's less than 46 beds. It's right at that threshold. So that qualifies them for that lower tax rate. And without getting too much into the weeds on that, the reason that those different tax rates exist is to try to make the tax more palatable to all providers, where it's not going to hurt any particular provider more or significantly. So that's why those different tax rates were created when that legislation was put in. After the bed tax add-on, there's also a Medicaid add-on that's specific to this year that looks at available funding through some of the provider relief funds, and divided that out so that it would get spread to facilities based on Medicaid days. So that's just an add-on that was put in place to distribute those funds based on the Medicaid utilization. There's also a line for a minimum wage adjustment, so that's just another effort. If the minimum wage were to increase, then the cost data that we have wouldn't reflect that. And so we have a way to make an adjustment to try to compensate for those increased costs that are tied to that. And then finally, the rate gets totaled up, and that's what the bottom line is. I think that hits all the rate calculation steps again, and maybe a good time to pause and just see if there are any questions about that calculation process.
Good idea. Let's start with Representative Carpenter.
Thank you, Mr. Chair. And Dave, that, again, you just talked about that Medicaid add-on. That was in this year's budget.
Yes.
And so that's what Representative Mason was influential in getting that done, to try to level the playing field for folks that had more Medicaid. So, yeah, I wanted to touch base with that. I think that's all I have for now. We're going to get to page 25 here pretty soon. And I have some.
It's really all pretty simple, you know, if you think about it. Representative Haskins.
Thank you, Mr. Chair, and thank you for the math and statistic lessons that we're receiving. It's always helpful to get the dust out of the brain here. But can I go just quickly on the CMI? What of that is public as far as, do the other self-assessment providers, do they know what each other's scores are?
They do. When the rates are posted, they're posted during that process that it's called the public notice process that occurs in April, when we share what the methodology is going to be, if there's any adjustments to it, and what the projected rates are for each facility. We also post what the Medicaid acuity is for that facility. Mm-hmm. So that gets posted in that public notice process.
So how do you prevent some sort of collusion going on? Because it seems like it would be to their advantage to all self-report something comparable. How does that get prevented?
Well, again, it's not that they're, easily saying, okay, I want to, maybe my case mix is 1.2. It's not quite that simple. They're completing an assessment on each individual each quarter. That assessment, if you print it out, It's 51 pages. And it includes things like how much assistance did you provide them in toileting, and how much assistance did you provide them with eating, and things like that. And it's clinical, it's beyond my comprehension. So if they were going to manipulate that, it would take a lot of, a clinical expert, to focus them on a specific idea that, okay, we're going to make this look better than it really is. But then that goes back to that idea, too, that I'm going to take that information and I'm going to use it to determine this is what your average level of care was, right? And I'm going to associate that with the cost that you shared with me. And now I've got the two linked up. If you inflated this, then it makes it look like you can do wonders with this small amount of money or smaller amount of money. And so it's that natural check and balance that I mentioned earlier, that if they're all doing the same thing, then they're all going to look like they...
No, and one last question, and I understand that, and it seems very theoretical unless I know who is checking it. Are you personally checking all these and then sending a red flag out, and then who enforces that? That's all. How's that?
Yeah, again, it's, there's some multiple checks. One, the survey group that does the health inspection surveys, when they review the medical record, they make sure, does it support the assessment data that has been submitted? So they may not look at every assessment, but they will look at some and review that. So that's one check that happens. And then, like I said, we look through and compare the values when we get them and make sure that, they're within some reasonable tolerance. If there's something that's changed drastically, which very seldom do we see anything like that, but we would point that out to the department, and then I'm sure that there would be additional review beyond that.
Committee, other questions before we proceed? Representative Epley.
Thank you, Mr. Chair. And this kind of bears back on what you worked on, which is the Medicaid add-on this year. And that varies. I have a series of just little easy questions. That varies from year to year, correct?
Well, this is the first time that that's been done, that Medicaid add-on. So the idea was there was this pool of money,
right,
and they wanted that distributed out by Medicaid days. So divide that total by the number of days that they anticipated would be provided. That's how the, I think, 1985, whatever it is, was determined. And then as the facility provides care and they bill for that, then they're going to get paid that for each of the Medicaid days that they provide. So that's how that, that idea again.
You work with other states, and didn't that vary from state to state also? Quite a bit. I mean, there was a big variance.
The provider relief funds were distributed in a lot of different ways through different states, yes.
And you would anticipate that's, again, you stated a one-time thing. That's not going to happen again? It's hard to know, but...
You're right. I anticipate, I mean, it's dependent on funding for it, right?
But it's federal money that passed down to the states, and then the states pass it on through that process.
So I assume that it will not occur again, yes.
Okay, thank you.
Senator Gossage.
Thank you. Real quick questions. We were told there were 24 positions that do spot checks, et cetera. Do you have any idea, because they said somebody else can answer the question, would that be you? How many of those are done a year?
Yeah, so I do know a little bit about that process from previous experience. So the federal rules are that each facility needs to be assessed or surveyed every 15 months. So they've got to average that. If they don't, then they're going to fall behind on their federal requirements. They also have to respond to complaint requests. So if a family member, resident, or other stakeholder complains about what's going on in a facility, that may trigger a separate complaint survey. So they have to do the annual surveys, then they have to follow up on these complaint surveys. So yes, they're doing all of those things. Does that answer most of what you were wanting?
Yes, so is the survey, so that's on-site surveys?
Mm-hmm.
And does the facility know they're coming?
No, they're not notified, no.
Good. And then the final thing is, you mentioned a survey in answer to Representative Haskins' question on kind of spot checking the assessments that are turned in.
Right.
That's different than the
Well,
on-site. Is that the
so
same team
when
of
they-
24 or a different team?
That's the same team. When they do their review of the facility, they're going to look at a lot of different aspects of the facility. And one of the things that they will look at is, does the medical records for individuals support the assessment? So there will be one of those team members during that process that will pull records, look at medical files, and make sure that those match up to what's been reported on the quarterly assessments that are done on each individual.
And to whom does one file a complaint?
There's a hotline that the state maintains. I don't know if it has, I'm sure there's an 800 number, and then there's other avenues, I think, that they can submit those complaints to.
Oh, I'm sorry,
And that's a separate division within,
separate division.
within KDADS, within the Department for Aging and Disability Services.
So we heard about communicating rate changes, and they said, and the fiscal agent, which is currently Gainwell, that's not you, that's Gainwell.
Right.
But trying to understand the difference between what Gainwell does and the MCOs do. The MCOs
Right.
are going to process claims, so maybe somebody else can answer that question
I
later.
think I
than
can
you. Okay.
touch on it at least. So Gainwell is the fiscal intermediary for the state. So rather than the state just making payments directly to the managed care entity or to a provider that provides whatever services under the Medicaid program, the state employs a fiscal intermediary that specializes in those payment systems. Before managed care existed, those were fee-for-service payments. So they would submit, those facilities, those providers would submit the claims to Gainwell or its predecessor, and then they would determine this is what the payment would be. And they based that payment then on the data from the state. The state said, well, this is provider A, and they get this rate for what they're doing. And that covers all the Medicaid program services. So Gainwell still does some of that fee-for-service processing for the state, because not every service that's provided falls under the managed care system. There are some that fall outside of that. And then with the managed care entities, since they came on board, basically what the state's doing is contracting with them to manage the Medicaid system. And it gives the state a little more flexibility in terms of what those providers can do, because the state has, or those managed care entities can do, the state has to follow, of course, whatever the federal regulations are to a T, right? If they don't, then CMS is going to come back and say, well, you made this payment in excess of what you could do. For the managed care organizations, the state says, well, I'm going to pay you this much to care for these people that fall into this rate cohort, and you need to provide all those services that I would have to have provided. But you can go beyond that, and we're not going to take anything back from you because we said you're in charge, you go do it. And so that's one of the benefits of that system. But the state still uses a fiscal intermediary to pay those MCOs. And so that's where they submit a form. I'm not sure exactly what the document's called, but it tells the state, the fiscal intermediary, Gainwell, they had this many individuals each month at each of these different cohorts, and they get paid that much, and then Gainwell processes that payment and submits that to the state.
Thank you. Thank you, Mr. Chair.
Representative Carpenter.
Just to make a clarification back, just so we're clear, this Medicaid add-on is state money that was just added on this year. Is that correct? It's not federal money that's passed through or any of that kind of stuff.
I'm going to have to defer that one to Brad or to one of the others.
I could probably answer it. It is.
You're correct, it is. It is state, so it is like the rest of the Medicaid money, roughly 40% state, 60% federal. It's not special federal money.
Thank you.
Representative Haskins.
Thank you, Mr. Chair. I wanted to follow back up on the federal regulations and the state being in compliant with the federal regulations. My understanding from working in the state is that the federal government may have a tier system as far as you're violating, you're not in a compliant. Does the federal government, when it comes to the CMS, do they have such a tier system for, you know, you're in the yellow zone, or you know what I'm trying to say? Or is it just, you know, no soup for you, you're done?
Well, their leverage, again, is the federal share of the payments that are made, right? So they're, the department has to complete a report each quarter that tells them this is what we paid in Medicaid payments, and these are the individuals that qualify for those payments, and this is the share that we drew on that, or we should draw on that. If they find, the Centers for Medicare and Medicaid Services, if they find that the state's out of compliance with their state plan, and again, the state plan has to go through a vetting system, so the state creates it, sends it to CMS and says, this is what we're going to do, and this is how we're going to pay these people for what we're going to do. If they approve that, then we're good to go, right? If there's some violation of that, then that's where CMS might come in and say, well, you shouldn't have made that payment because you weren't complying with your state plan, and so we're going to take back some of that federal money that you drew down based on that. So that's how that process would work, I think.
And I appreciate that. And I guess, how would we find out when it comes to the 60 budgeted enforcers and we only have 24, and these facilities are supposed to be evaluated every 15 months? How do we know if we're in compliant with that? Because that seems pretty intense to have 24, not even 50% of what we should have budgeted. How do we know if we're in compliant?
Right. So all of those surveys are required by CMS. So that data actually goes to them first. So that's where they track that. And then again, they keep those statistics in terms of how frequently are we getting into those facilities to do the surveys. And then I'm sure that the state's tracking those as well. But we're kind of getting beyond my scope, I guess. And so I probably should let Brad or others comment on that. But that's generally, again, CMS is going to have their own statistics because they're tracking that, they're getting that data. The state would have it as well because they're performing that work.
And thank you so much. I would be interested, not maybe today, or not right now, but later, is like, how in compliant are we with these audits? And, or where do I find that information if it's on the federal site or what have you? So thank you.
Yeah.
Committee, other questions? Representative Bryce.
Thank you, Mr. Chair. Thank you, Dave. This is very informative. Just had a quick question. If you have any information from other states that have had Medicaid expansion, what's the effect on nursing facility reimbursement? Do you have any knowledge about that? Thank you.
I don't believe that Medicaid expansion per se has impacted nursing facility reimbursement so much because, those individuals, again, that nursing facility program is an entitlement. It's required as part of your Medicaid program if you participate in it. And to qualify for Medicaid services, nursing facility services, you have to meet a functional level of care that is pretty well defined and pretty universal, that, you've got to have significant functional issues to be there and to qualify for that payment. So I don't think that, when you expand Medicaid, that you bring in individuals that weren't already there very often.
Okay, thank you.
And those populations are already covered, elderly, disabled, that kind of thing. Further questions? Well, feel free to proceed.
Okay. Slide 24 is just a summary of the limits that were imposed for this year, just some statistics for this current year. I do believe that we have the wrong table in there, and that those amounts, instead of, I think it should be 5515 for the operating cost center.
Yes, and there's another sheet in your slide deck to replace that.
Okay.
Committee.
I apologize for that. We just got an old table included. The average rate for this year came out to $276.36. So that's the average nursing facility payment rate. That does include that Medicaid add-on that was kind of an out of the ordinary amount. So that's inflated maybe to some degree because of that. But that is the average rate as of July 1. And then the next slide, on slide 25, just for background information, we shared this is what the average rates were for the last, well, nearly 15 years or so. And not only that, we've shared what the limits were, what the cost coverage, I spoke about cost coverage before. Cost coverage is generally, again, around 95% statewide for all services, 90 to 95%, and generally a little bit above 95% for direct care services. So that just gives you some background information if you want to track through that. You can see periods. Generally, the rates are rebased every year using new cost data, but there have been periods where provisos have been included in the legislative appropriations bill that said don't do that because budget's tight, and so the agency's done things differently. Slide 26 talks a little bit about one of the things that's looming on the horizon for the Medicaid program and the nursing home reimbursement, and that's this patient-driven payment model. Like I said earlier, Kansas and many other states have relied on the resource utilization groups, the RUG system, for nearly 40 years. And that system is no longer going to be supported by CMS after this month. So we can make the rate calculations that we do now for January 1 of next year, and that'll get us through the end of this fiscal year. But then for July 1 of 2024, we need to switch our calculations to the PDPM system. And there's not a lot of difference to that. It's still the same idea. You have an index that tells you this is the level of care of these residents. And we can associate that with cost and do that neutralization and Medicaid acuity adjustment that I talked about. Those two different things can still be done. The numbers under the PDPM system are a little bit bigger. So that just changes how they look. It really doesn't change the impact that they have, except for one thing. Because that system carves out the therapy pieces, it does look like that there's going to be just a case where the Medicaid acuity is now closer to the overall acuity. So that idea before where you were talking about, well, how do you carve out Medicare's influence and that acuity adjustment that causes that proportional calculation that we do. Because under PDPM now you've removed the therapy influence, it makes Medicare and Medicaid look a little more similar than they did before. And because of that, it looks like that's going to have an influence to drive rates a little higher as well. The bigger driver of rates will be new costs. Obviously, the last few years with COVID and the changes in how nursing homes managed infections and such has really driven costs through the roof. So there have been significant increases over the last 2 years, which you can see on the previous table. That's probably going to continue along those lines, maybe not quite as great, but this is also going to be another factor that's going to be in play this next year is that move to PDPM. And I think what I did there is I just actually covered most of what's on slide 27, which again, the point of that is that we'll move to PDPM July 1 of 2024 because we're basically forced to do that. It doesn't change the calculations much, but it does probably make the calculations look a little more like Medicare. And so it's a little less differentiation between the two than what we've had in the past, and that's probably going to add to any rate increases that we see for the next year. So then the last couple of slides are just some resources for you if you want to dig into things more, if you're not terribly bored with everything we've gone through already. And with that, I'll stop again and try to answer any questions that you guys have.
Okay, I believe Senator Gossage has a question for you.
Yes, I'm so sorry I had to step out of the room, but you evidently addressed the change for 23 and 24. What was the reason given for such a high increase?
So, COVID expenses were a large part of you're looking at the table on
page 24, slide 25.
Yes.
But this is the difference between 2022 and 2023. I could see if this was 2020 to 2021 or 2022. I'm trying to understand 2022 to 2023.
So again, when we set the rates, we're looking at 3 years of cost data to set the rates, and we have to look at what's historical data, right? So in 2022, we were looking at costs from 2017 through 2019. In 2023, now we're looking at costs from 2018, actually it was 2019 through 2021, so that's where you had that big jump. Now you've got several years that have COVID expenditures and changes in staffing, you know, cost that got in significant increases.
So then hopefully we can see that go down in future years?
Unfortunately, I don't know, you know, I think it will flatten out. I don't know that it's ever going to retract and go away completely. For one, facilities are going to continue to manage infection in a different way than what they did in 2019. If you compare practices today to what they did in 2019, it's just a different deal than what it used to be. And then the influence or the impact that all of this had on staffing too is not going to go away. So I just don't think you're going to see it go back completely.
Sorry, I guess what I'm saying is percentage of increase.
Yes,
So
yes.
the
If you're looking at the
percentage of
percentage of increase, I would anticipate that, yes, that's going to come back to.
Sorry, I wasn't clear on that.
Right. No,
Thank you
I
very
see.
much, and thank you, Mr. Chair.
Representative Carpenter.
Thank you, Mr. Chairman. And Dave, you may not be aware of this, so part of the 23-24 increase that you're seeing there is also before, when we were doing, until 2 years ago, when we were doing the cost evaluation, the cost report, KDADS was not getting that cost report until after we had already left the legislative session in May. So it was actually 4 years behind instead of 3. So this is a second year that we've done the cost report. The first time that we did it, we actually guesstimated, and it was within $2 or $3 million, but we actually guesstimated what the cost report was going to be, and we came out very close. This year, the nursing homes have had their cost reports in early, and we were able to capture that actual data. So that's what happened on those. Plus, we did the statutory requirement of 3% of reimbursement rate, increasing by 3% for, I don't know how many years. It was one. I think there were several years that there was no reimbursement increase on that during the 2010, 2012. You can see kind of how this goes. There's minus figures here in 15, and there's minus figures in. So we weren't even doing the cost report. We were actually cutting the budget, you know, even more than that. And that's what's caused, you know, it's just kind of we needed to get caught up or else we were going to lose this industry. So anyway, just a little background of that. You may not have been aware of that just because it was state politics.
Committee, other questions? I have a quick one for you. We talked about earlier with one of the other conferees about there might be different rates paid to different providers. On the bottom of page 24, you're showing the average rate for July 1st is $276.36. Now, that is not the base?
No.
Okay.
So again, the rate is specific to each facility. So again, if a facility has their costs are much lower, historically, they're going to get a lower rate. And then the costs are also adjusted for that facility's Medicaid acuity. So that could also make their rate go up or down if their acuity for Medicaid was much different.
Okay, how do we know what that base rate that the MCOs are required to pay is? Is it a?
So it's determined on a facility-specific basis. So the state shares, the department shares with the MCO that these are the rates that were calculated for each facility, and that becomes the minimum that they have to pay that facility.
And again, that can vary from
Yes.
facility A to facility B.
Right, yes.
Okay, all right. Committee, other questions? Representative, or Senator Erickson, excuse me.
Thank you, Mr. Chair. Thank you so much for this. And I just have a couple of basic questions. So I'm looking back at our first presentation where it shows how the money flows in. And so can you tell me, or do you know, or maybe it's coming up later? So the federal government gives money, state government gives money to the state Medicaid agency. And there it flows down, right, into vendors and providers. So for $1 that the state agency receives, how much of that goes to providers? Do you know?
So every payment that they make to providers is matched with federal funds. So in Kansas, again, that split is usually 60-40. So Kansas puts up $1, they draw down $1.50 from the federal match, and the provider then gets paid the $2.50. So when you look at the total Medicaid budget, I don't know, like, I guess what maybe you're asking is what percent is kept for administrative work that the state provides or the state performs? Is that?
We have, from what I can tell, we have KDADs providing some services. We have you, we have, is it Gainwell? And we have the MCOs.
Right.
So how much
Actually goes to the
how
provider.
much goes to the providers and how much is paying for?
Services.
That's right.
Yeah, and I don't have that data myself. I don't know, but I'm sure that somebody can provide that for you. And that's really a big, big picture. You've talked about multiple agencies. The Department of Health and Environment is the state Medicaid agency, so everything flows through them. KDADS manages several programs for Medicaid, so I think the big answer is probably coming from KDHE. This is what our total Medicaid program expenditures are for admin and services. This is the payments that go to the managed care organizations, and then of those payments that go to them, this is the amount that actually went to the providers. But I think that's got to come from KDHE. I don't know that, KDADS may know that. I certainly don't know that myself, but it would be compiled by KDHE.
Thank you. Thank you, Mr. Chair.
Committee, other questions for Dave? Representative Epley.
Thank you, Mr. Chair. And just looking on slide 25, and so I'm kind of reflecting on COVID times versus the fact that we're out from under that, and looking at the column on statewide average CMI, it's never gone down. It just continually rises. Mm-hmm. And that calls to question, now that we're out of COVID, is that a reflection? I mean, because it jumps up a lot in the last, 2 or 3 years. And I realize that's an average, but will that ever trend back down, or does it just continually go up? Or do you know?
I don't think it will trend back down, and I think you want to see it continue to go up because the state also has multiple programs to try to provide care for people in the community, right? And that's been an impetus of the Medicaid program and the long-term care program since at least the mid-90s, to try to get people cared for in the community as much as they can. So what you're seeing is, and this was brought up earlier and I didn't mention this, but I think I noted that there's about 10,000 Medicaid nursing facility residents every given month, or somewhere around there. It's maybe in the high 9,000s now. I've watched that for 25 years, and it's slowly gone down every year. And at some point, you know that the baby boom wave is starting to work its way through the long-term care system. You're going to have greater population numbers. We've watched that number, expecting it, okay, it's got to turn back up at some point, right? And it hasn't, and it largely hasn't, I think, because people are being cared for through home and community-based services, so they're staying in the community longer. And what that means on the other side of that is that the residents that a nursing facility is caring for are higher acuity people. They're the people that really couldn't stay in the community any longer, and they went to the last resort. Now they're in the nursing home, and they're higher level. And I shouldn't have used that term. They went to what they needed. They needed the nursing facility to provide their care, and so now that's why that acuity keeps growing. And I think that's a trend that I think, again, you want to see. If you can, you want to see that number of people in the nursing home continue to go down, the number of people in the community to go up. and the level of acuity in the nursing home to continue to go up to show that, yeah, we're finding ways to care for people in the home, in the community, and the nursing home stepping in when they have to.
Representative Carpenter.
Thank you. And just to follow up on that, that's kind of what this is all about is, we have PACE, we have our SILs, we have the frail and elderly waiver, we have all those things. And so we've shot ourselves in the foot in a way because the cost of the nursing homes is expensive. And we've kept these folks out of the nursing homes. We pay by day. And so we have a declining, and I really think the numbers are closer to 8,500 or 8,500 and versus the 10,000 that it was before COVID. So that's what's happened is the occupancy is down 80% is their break even. So when it gets below that, they're losing money. And so that's what we're fighting. It's way better to have folks in their home and taken care of by home health and that kind of stuff. But on the other side of that, when you pay by day to a nursing home and their occupancy slips below that, they just go out of business. And we've lost 500 beds, in the last year. And so that's why we're here.
Committee, other questions? Seeing none. That's amazing job. Thank you for your presentation and answering the questions. I need to ask, we have a nice group of conferees that were supposed to testify this morning. Is there anyone who cannot come back after lunch? Because I'd kind of like to group these all together. I don't see anybody who's not willing to come back after lunch. So we're like 15 minutes early for lunch. Let's just go ahead and recess for our lunch break, and then we'll reconvene here at 1:30. Thank you. We're a few minutes late getting started. We'll go ahead and call this back to order. And as you recall, we were going to hear presentations on nursing facility reimbursement rates by individuals, providers, and organizations. So the first person I would call to the podium would be Linda Mowbray. Welcome.
Thank you, Chairman. My testimony says good morning, but obviously good afternoon to you all. So happy to be here. I'd like to start by, first of all, thanking all of you. You made a huge difference to the nursing home profession last year when you provided for the Medicaid add-on. As I stood before you in several different committees telling you about the closures, you know, in the last 3 years, we'd had 26 nursing homes close. We have probably 7 counties with absolutely no nursing home at all. A few other counties that have just a long-term care unit of a hospital, but no freestanding nursing home. Since your Medicaid add-on went on to the rates, July 1, to my knowledge, we have not had a single closure. Knock on something, yes. Our providers are grateful. They needed that infusion. And I wanted to take the opportunity, if I could, to go back to Mr. Dave Halferty's presentation on page 25 specifically, where it showed the historical rate-setting parameters. Looking down at the very last row at the bottom and your column furthest to the right, you'll see that total costs, because of your add-on, were right at 100%. Direct care costs were at 94.66. That's really good. But without the add-on, we just wouldn't have been able to keep pace. And if you look back historically, there are years where we've been in the 80s. And that's 80 cents on the dollar for reimbursement. Now, you've heard a lot about the methodology this morning. And yes, it is complex. And there are so many different components and things to go into it. The bottom line is, right now, it's not quite working. It's not quite keeping pace. And I'd like, if you would, to turn your attention to my testimony. What I have for you, starting on about the 4th page, is the detailed explanation of the very complicated, very complex Medicaid nursing home rate methodology. And it talks in detail about what we went over this morning. It talks in more detail than you probably want to know about. But if you're interested into the weeds of how those rates really work, this document from the Kansas Register, June 8th, 2023, actually spells it out exactly what the parameters are, what goes in each cost center, what the incentives are, what they're based on. And then at the very, let's see, starting on page, it calls itself 745. That will give you by city the actual rates of the nursing home starting July 1, including the add-on. So as you can see, you can look through that list and find the cities that are near the communities that you represent. You can see the actual per diem that the facility gets based on their cost reports, what their CMI is, and that case mix index is the weight, if you will, for care. as has been explained earlier in the day. Now, what I'd like to do is take a moment and talk you through getting to that CMI, getting to that case mix index. As Dave Halferty had mentioned, if you print out the document called the MDS, or Minimum Data Set, it's 52 pages long. It's between 500 and 700 questions, depending on how you answer the question above, whether you get to skip over 2 or 3, or whether you have to fill in all the blanks. And that's called a minimum data set. It has to be done on admission for every nursing home resident, regardless of their payer type. More frequently for Medicare residents, but for our Medicaid folks, done quarterly, or when there's a significant change in their condition, either improvement or decline. That minimum data set not only sets their CMI, their weighted care score, but it also sets their care needs. So when you ask about accountability, Representative Haskins, one of the things that pardon me, the survey team looks at is based on how you answered that minimum data set, you will need to care plan for that resident. You will need to work in conjunction with their physician to come up with a plan to address their specific need. And if you're not addressing that specific need, then it's going to trigger on down the road, whether it's at survey, whether when someone is doing an audit, why didn't we address this? So there are checks and balances within the system, and there is really no advantage at all to saying somebody needs more care than what they really do. Because if you say they need that care, then you better have a plan in place on how you're going to provide it. So that piece of it really does check and balance itself. Now, the big change that Dave Halferty was speaking of, we are going from a RUGS-based system, and RUGS is that utilization group, resource utilization group, to PDPM, and that's the patient-driven payment model. And the issue that we as the profession are having is that there is no crosswalk. You can't say that if you were in these 5 RUGS categories, you're now going to be in this one PDPM category. There is no direct crosswalk. So from a budgeting standpoint, we don't know where our residents are going to fall. We don't know what that dollar amount on the PDPM is going to be. And we don't know what the impact to the state budget, to our reimbursement rates, and to our overall ability to care for our residents is yet. Modeling will be done, and KDADS has been an excellent provider, excellent partner at having us stakeholders come to the table and talk about. They are very willing to share information as they receive it from Myers and Stauffer. If decisions need to be made about, we could do it A or B, which do you profession like best? They take our input and they do listen to that. One of the issues that we have had in the past with KDADS is that we have encouraged them for years, ask what you need. Ask the legislature for what you need. Don't go for a lowball amount or a budget neutral amount or an amount that's just a statutory requirement of 3.5%. look at the numbers. Look at the projections. Myers and Stoffers have been at this for a really long time. And if you're projecting caseload to be X, and the amount of money that it's going to need to take care of them is Y, then please go to the legislature and ask for that amount of money. And that's where we kind of came in last year and said, you know, this budget's great. It checks all the boxes, but it's going to be short. And so we talked about what it would look like to have the add-on. And the add-on got us closer to whole than we've been in a really, really long time. So one of the first requests that I have for this reimbursement committee, as you're looking going forward, is to take a look at how long is it going to take to get to parity? How long are we going to need to collect data and try to figure out apples to oranges and what that looks like on the budget? And give us a grace period, up to 3 years. It may not take that long. We may be able to figure it out in the first 6 months or year. To say, yeah, this is working, this is not working, it's costing the state way more than it should, it's not costing the state as much as it should, and we may not need that add-on. But for this coming fiscal year, respectfully requesting that you give us that safety net of that nearly $20 per day per Medicaid resident so that our providers have the ability to transition. Now, not only is this major reimbursement transition going on, you may have heard that CMS and the president would like to see higher staffing in our nursing facilities, and in fact have considered in their final rule to have a staffing ratio that is one size fit all, despite what we have seen on these CMIs, that no two facilities are alike with the type of residents they have and the care that they need. And CMS has decided that our licensed practical nurses, our LPNs, who are part of our integral structure to the nursing home communities, they don't count. They don't count as nurses. So we have this whole group of workforce that's just, they don't count. So part of what my association is doing, Leading Age Kansas is doing, CASE is doing, and those of us that have national organizations, respectively, are doing it across the nation, is we're trying to put a halt to this. You know, let's not do the one size fits all. Let's not do the cookie cutter. CMS's own study showed that having an arbitrary number did not guarantee quality of care. But we don't know if we will still be held to that standard. Right now, it looks pretty looming that we will be held to that standard. And so the problems that we have are, it's going to take a whole lot more money to get 24-hour-a-day RN coverage. There are very few unemployed RNs out there that want to be employed. And those that do may not choose long-term care. So you've heard it over and over and over, workforce capacity, workforce capacity. The good news is we are getting better. We are not back to where we were pre-pandemic. And quite frankly, we did not have as many able and willing bodies as we would have liked to have had pre-pandemic. But my members tell me that in some areas of the state, staffing, they're coming back slowly, but they're coming back. When they were hit with their income tax bill, not understanding what it meant to be a 1099 worker and not have anything withheld, having a full-time job with an employer that does the payroll withdrawals and pays those taxes on your behalf is a pretty attractive thing. Not having benefits, the idea of flexibility is still there. People want flexibility in the workplace. And that's going to be on us. That's going to be on the nursing home profession. We've got to get creative with how we make our shifts more attractive and meet people where they're at and accommodate their needs while taking care of the residents that we need to take care of. So again, with that cliff looming over us, having that extra Medicaid add-on continues to give us some flexibility to offer higher wages, better benefits, staff retention bonuses, things that will help improve the culture within our facilities so that people want to come to work there. Because people that have worked in nursing homes, many of them will tell you it's the hardest thing they've ever done and it's the best work they've ever done. And that's why we have as much staff as we do, because people commit their lives to long-term care in many. So the next point that I have is, as we talked about earlier in the day, upper payment limits. We talked about, you know, how much is too much? What can we put in? How much, you know, how big is the pot, basically? I believe that at one point the legislature did approve a provider assessment for the MCOs, and that it was not enacted. Why it was not enacted, I don't know. But it's there, and it's a mechanism to tax the MCOs, to draw down federal funds, and have more money for the Medicaid program in Kansas in general, not just nursing homes. By leveraging the MCOs, you make the pot just a little bit bigger so that all the stakeholders and Medicaid participants have the ability to draw in a little bit more without taking resources from the state. Because we're not the only ones that are going to come out with our hands out. We're not the only ones that are seeing higher labor costs, higher food costs, higher transportation, gasoline costs. You know, we nicely tuck it under the term inflation, but inflation doesn't begin to describe the day-to-day expenses when the drug costs are going up and your insurance is going up and tuition is going up. Every aspect is going up. So there are a lot of different agencies that will be coming to you. We need more. We need more. So by using some of these mechanisms that are already on the books and leveraging the MCOs, just like you do the nursing homes and the hospitals, they pay a portion, put it up. The feds do their 60% match, and you have that much more money coming back to the state to spread out through the Medicaid program. So I'd really ask you to consider looking at that. The last piece is a little bit tricky because, again, it's in the weeds. The MDS, under the RUG system or the PDPM system, neither one captures the time it takes to take care of a person with cognitive impairment or behavioral health needs. They don't need an IV. They don't need a physical therapist necessarily. They don't have a wound that needs to be taken care of. They're not up here on that hierarchy of needs that require a registered nurse. or that count towards a higher. But I believe that most of you have had experience with individuals who have either had cognitive issues because of dementia or Alzheimer's, or that you've had exposure to individuals that have mental health needs and behavioral issues that may go along with it, substance abuse disorders, require a lot of time and a lot of care and a lot of compassion that simply does not count on the MDS. Doesn't count. You know, maybe the time studies show that you can give a shower in 30 minutes to the average person. They have a cognitive impairment. It may take 30 minutes to get them comfortable enough to walk into the shower room with you. Calmly and compassionately get them into a bathing gown and adjust the water just right and make sure that they're not frightened and that they're having a good experience, not a trauma, not a flashback to some other bad experience, and none of that time counts. But if you don't take that time with the person, you're missing the point, number one, of what their needs are. Number two, you very well may be traumatizing them yourselves inadvertently. And number three, it's just the wrong thing to do. That's not how we treat people. That's not what they deserve. So I'm asking for you to consider looking at a behavioral add-on. And a behavioral add-on would be based on, you know, what are their needs? If the individual has behavioral health or substance abuse, chemical dependencies, they may very well have triggered for a level 2 PASSAR. And that screen is to help determine the special needs of individuals with mental health issues that come into our nursing homes and what we need to do to provide care for them. And that's great that we have that program and it identifies those needs, but there are no funds behind it for the nursing facility to provide that care that they need. Now, for the cognitive impairment, there are many different scales out there that could be used to help set a baseline for what extra dollars are needed for care for Mrs. Jones because she needs X, Y, and Z. There are several companies out there that are helping with behavioral health add-ons in other states. I know that Colorado is working very aggressively to get an add-on. Washington State has an add-on, and they have approached the Healthcare Association at what can we do in Kansas to look at a behavioral add-on. And I would ask you to consider that as an option as we go forward and investigate more and see what those different behavioral add-ons might look like, what the price tag would be, and how we could leverage the funds to get them. I should have said this at the very beginning. I began by saying thank you, but I didn't tell you who I am. I'm Linda Mowbray. I'm with Kansas Healthcare Association, Kansas Center for Assisted Living, and we represent both for-profit and not-for-profit across the long-term care gamut in the state. We have state licensed only. Those are your assisted livings. We have nursing facilities, skilled nursing facilities. And our little crew of 5 people have been at this for a really long time, have a passion for it. All of us are registered operators. 2 of them have worked in nursing facilities before. I spent my first 14 years working in a skilled nursing facility, and then the last 20-something with the association. So the passion, the dedication, and the knowledge is there. So we would ask you to please call on us. If we don't have the answer, which we might not at our fingertips, we will help find it for you. We want to work together to partner and provide solutions. We will be more than willing to sit down with you and again, kind of do a one-on-one as to how some of these things work and the steps and the walkthrough. And I just applaud you for taking the time to do this. You don't know what you don't know until you start hearing from the folks that deal with this every day, and then you're like, wow, that's a lot of information. So again, thank you. I'll stand for questions at the appropriate time, and I really appreciate this opportunity.
Thank you, Linda. Let's see. We'll start with Representative Bryce.
Thank you, Mr. Chairman. Hi, Linda. Thank you. It seems that the nursing facility budgets are going up, as you had said, and staffing shortages and so forth. I was wondering, do you know of any studies that have been done how we can leverage technology, monitoring, video communications, something to where people can stay at home longer, or in the nursing facility you can reduce your staffing needs and reduce costs that way? Thank you.
Mr. Chairman, there are programs that are available out there. Keeping people in their own home in the least restrictive environment. If they need to have care outside of the home, are they best served in Home Plus or assisted living, or do they need the nursing home? There are ways to help people, and part of that is the telemedicine, the electronic monitoring, the, pill reminders that open up and take the pill. But when it comes to taking care of people, you can't substitute a machine for a person. When an individual is having a bad day or is having an anniversary of something sad or is celebrating a good day, you got to have that personal connection, and that will help them thrive.
Committee, other questions? Senator Fagg.
Thank you, Mr. Chairman. Linda, thank you for your presentation. This is getting off the beat just a little bit, but I wanted to you're in a position that you might know this. I had read somewhere that Kansas ranks 49th on energy efficiency. So I guess my question to you is there anybody that goes out to these nursing homes and looks at windows, heating and air systems, that type of thing, to where if we had to spend some money on that it would save us some money in the long run? Just wondered if there's any of that kind of work done anywhere.
Right. Mr. Chair, there is a program that Kansas Healthcare Association is involved with, and American Healthcare Association, our federation partner, is involved with, called Cleary. And they will do just that. They will look at your physical plant. They will look at the contracts that you have with your utility companies, help you renegotiate those if at all possible. Pardon me. Make recommendations for, changing out and physical repairs. The money they save on the utility side could very well be used to do some of those capital improvements. If that money is not enough or isn't a substantial amount, then you're back in a situation where the facility is paying for a good or a service that, yes, it will help them save money in the long run, but it's made up so poorly on the cost report at that 105% of median, that the capital improvement projects are just, they're not happening right now.
Representative Carpenter.
Thank you, Mr. Chair. Linda, thank you for being here. So, absent money, obviously, we've been putting a lot of money into this. What policy changes can we make to make your industry more efficient what can we do to help you? And I realize when I say that, I realize that a lot of what you do is CMS regulated and that kind of stuff, but what can we do on the state level or anything can we do to help you be more efficient?
Mr. Chair? There are several programs out there, Representative, that look at the measuring stick differently. CMS says that we need to have the survey, and they have a book that's about 5 inches thick that tells the surveyors what they need to look for, what the deficient practices might be, how to judge them, how to scope them, how to, write them up, and then if there's a fine issued, how much that fine's going to be. There's not a page in that book that says how to do it better. There are programs out there, whether it's the Baldrige Quality Awards or the Joint Commission and their certification process, where instead of looking at a program, a nursing facility, and saying, wrong, 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 fine, 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 it's root cause. Let's look for the system. Let's see what we need to do to fix it. That's what we need. The stick has to be there. CMS says it does. But we need the resources and the help outside of that to do better. When you walk into an area after a tornado, where do you begin? Where do you even start to pick up the pieces? So when you have a system that has been gone through a pandemic and the whipping child of the media and whatnot, you look at it and say, where in the world do we start? Well, we start with the why. And the why is the residents. And what do we have to do to make it better? And we're so busy in the facilities filling out 52 pages of MDS assessments every quarter on every resident and preparing for survey and doing everything else that the CMS requires that we don't have the bandwidth to create those programs. So bringing in those initiative programs like Baldrige and like the Joint Commission would help give us the tools and the starting place.
Thank you.
Committee, other questions? Senator Fagg.
Thank you, Mr. Chairman. Do you have, Linda, in your, where you work at, do you have the goals? Do you guys set goals for your agency?
Okay.
Okay, and do you monitor that or review them? Is that something that is public, that maybe we have a copy of that sometime? I'd be interested in what your goal, how you review those.
Right. So within KHCA, for our 5-man crew, yes, we have a strategic plan and we have a board and we have our own internal goals. What I think I hear you saying is, do we have a plan for our members? Do we have goals for those nursing homes? Okay. Within our agency, yes, we have benchmarks that we look towards. When we have our nursing homes and we have our assisted livings, we have a national program that is connected with the Baldrige. And we want to see an increase of 5% every year of participation in that Baldrige program. Not only does it help them grow and help their systems, their quality measures go up, their overall performance goes up, satisfaction goes up. So yes, those are the kinds of goals that we would set for ourselves, is to encouraging our members to do those kinds of things.
Further questions? Representative Carpenter.
So could you get, I've never heard of that, so could you get that to staff so that we could get that out to the committee about the Baldrige program? Wouldn't that be a good idea?
Yes, sir.
Thank you.
And if I might, we have a silver winner in the state of Kansas on the national level of Baldrige, and they will be acknowledged at our national convention in Denver first part of October. So, you know, that is, the Baldrige system is one of the gold standards of quality improvement. And so I'd be very pleased to get you the information on that program.
That would be very good. Other questions? I was wondering on your request number 2, did I hear you say that that had been enacted by the legislature at some point, but never executed?
That's my understanding, sir.
Your understanding,
Yes.
okay. Absent that, just give me a real-world example of what this might look like. We legislature would impose a tax on MCOs, like a privilege fee or something like that. That money would go where?
That money would go to CMS, and then CMS would do the FMAP, the matching federal funds. And if it's the same for MCOs as it is for the nursing homes, every 40 cents we collect from the MCO, they would provide that and an additional 60 cents back.
Okay, all right. Last chance, further questions? Seeing none, thank you, Linda.
Thank you.
Rachel Monger, please. Welcome.
Thank you, Mr. Chair. I am Rachel Monger with Leading Age Kansas. We're the State Association for Nonprofit Aging Services. Very happy to be here today, and I'm very lucky to get to go after Dave and Linda because they did such a great job of walking through those, as we've said, very, very complex formulas. So some of these recommendations that are in our testimony as nonprofits, Linda went through as well, so I'm not going to belabor the point, but I'll just give our little perspective. As nonprofits, we make up almost half of the nursing homes in the state, which is a nice thing about Kansas. We've got a nice, healthy balance between the two types, and have a lot in common when it comes to the reimbursement and the issues that we're seeing and the struggles that we've had. We absolutely agree with Linda on the Medicaid add-on adjustment and the benefits that could come with continuing that on into a future year. Though that money started getting distributed July 1st, and the positive effect it had was immediate. We were out on member roundtable meetings all around the state talking to providers who had just a month prior started getting those payments in. And for the first time in a long time, as Linda noted, we started hearing from members saying, we're getting job applications again. We've been able to recruit some of our staff back from staffing agencies. And we are still a long way from good on the staffing shortage problem, but based on the chasm we were stuck in these last few years, even just getting these job applications in again for nurse aide positions just feels miraculous. And so that money, immediately has been put to good use. And if we are able to continue that into the future, I know it will continue to be of great benefit to the care that we're able to provide. Next is that behavioral health add-on payment. We see the exact same situation that Linda sees with her providers, which is we're able to capture physical health needs that we're providing for our residents, but that dementia care aspect is very difficult to capture on these assessments that we're required to do and inform our payments. Dementia care, high quality dementia care is very individualized, is extremely resource and staff intensive, and absolutely does not respond to anyone's efficiency needs when it comes to care. And so on that direct health care cost center and that staffing component, that shows the biggest losses that our members show are in that staffing category of the amount of money and the amount of staff they hire to provide the quality of care that they believe is necessary does not match up with the reimbursement that the state gives them to actually provide that care to most of their residents. The next one we'll talk about is the quality incentives that came up a few different times this morning. We do have quality incentives in Kansas around staffing, staff retention, quality measures, person-centered care, and that's a great thing. I think the problem that our members see with the quality incentives is that they're mostly just on paper. Because from our perspective, for a quality incentive to actually be an incentive effective is that it's something, it's a reward, and it's a way to cover some of the higher costs that come with achieving that top tier quality performance. However, in order for that to really work, the base payment that it's coming on top of needs to be adequate for you to even provide necessary quality of care. And in our experience, our reimbursement rate has not been at that level. And so you have incentives that kind of work unfairly for Medicaid, because if your Medicaid payment is not adequate, well, the more Medicaid you're taking, the less and less likely it is that you're going to be able to achieve the top tier quality that's going to get you that incentive, if that makes sense. It makes it, the more Medicaid you take, the harder it is to ever even reach an incentive factor to see that reward. And so if that's the case, then what are these incentives really doing? So we would ask is for us to look at those incentives, make sure they're relevant and transparent, but also make sure that they are achievable and actually doing what we need them to do in spurring quality and investment in quality within our Medicaid providers. Next is that real and personal property fee, which also came out this morning, which was, I didn't know that. It was set in 1985. It makes a whole lot more sense now why our members, this comes up a lot when we talk about reimbursement. For our members, the vast majority of them are rural providers, nonprofits, in communities of less than 4,000 people. And a lot of them are stuck in very old buildings that were built in the 60s and 70s. And they take care of mostly Medicaid and rural populations as well. And an aspect of the Medicaid reimbursement that's not keeping up with their needs to keep up with their buildings, to make improvements, to get new windows or roofs, or even do bigger renovations to ensure safety and dignity, dignified environments for residents is very, very tough when you're not getting the reimbursement you need to actually keep up with those costs. And so that's one that comes up a lot for our members. I know that Dave Halferty, he did such a great job going through all of this. And he said, well, yes, it was set in the 1980s, but you can rebase it up to modern times. But the problem is it's still capped at that $10.74, I believe it is, which when talking to our members is not even close to what they would need to do any of the improvements on the buildings that they really need to do, especially in our rural communities. Another recommendation we have is a critical access nursing home model. We all know we have critical access hospitals, and we would ask that the state of Kansas take a look at or consider a similar model for the nursing home side in our rural communities. Much like critical access hospitals, our nursing homes are in communities that really, really need their services. They play a huge role in their communities, and we know, just like on the critical access hospital side, providing long-term care in smaller communities is a bigger challenge. It tends to be more expensive, including with staffing. And it would behoove us to look at these types of models for the growing older population that are in our rural communities. And if we want to keep these services and preserve them, and not have to uproot so many older people away from their lifelong communities and their families, that we should probably start investigating these types of models. Another recommendation, again, I think I have 7 total, but annual cost rebasing. Another issue came up this morning, which is we do 3 years, every 3 years cost rebasing, which is set in statute, and that was passed long before my time, so I don't know what we originally asked for, but we have 3 years. And in recent times, as we've talked more and more about the adequacy of the reimbursement formula, I've been hearing that from more and more of our members of questioning harder that 3 years. And looking at other states, I know the lady from the NCSL this morning talked about there are 20-something states in Kansas that do annual rebasing or every other year rebasing, and they've done it successfully. And in Kansas, when we brought that up, sometimes we hear from the agency or maybe someone else out there that, well, if you do 3 years, the benefit can be that you smooth out any big fluctuations in your costs and your reimbursement. It helps kind of smooth things out. It's less volatile from year to year, is what we've heard. But we would really encourage the state of Kansas to look at these other states, see how successful that model has been in better capturing more up-to-date costs, and whether that increased accuracy for reimbursement outweighs any concerns about rate volatility for providers. And I think I've made it through every one of these recommendations. I really appreciate the time, and of course, I'm happy to answer as many questions as I can.
Thank you, Rachel. First question comes from Senator Holster, who is on WebEx. Senator? Senator Holster, are you there? Maybe we can mute that and we'll get back to her. So, sounds like it's getting kind of rough. Committee, other questions while we wait for Senator Holster?
Okay, I'm
Senator,
here now. I'm having all kinds of fun stuff going on with my computer.
Okay, please proceed, Senator.
Okay, I actually had my question answered earlier, so sorry about that.
Yeah, you have nothing then?
Correct.
Okay, all right, thank you. Senator McGinn.
Thank you, Mr. Chairman. Rachel, on the pass-through payments for federal staffing minimums, the proposed rule, it's a proposed rule. Can you tell us where that's at?
It was introduced September 1st. They have 60-day comment periods with CMS that will close in November. And then after that, it's anyone's guess when they will come out with the final rule. And so I didn't harp on it too much today just because it's not in effect yet, but it is something that is looming, that Linda did an excellent job walking us through the concerns there, that we have the same on the nonprofit side. In particular, the RN coverage, 24 hours a day, 7 days a week, would be an immediate killer for us. And I know in my testimony, our initial pass looked at an additional $26 million. But doing a second pass on those costs, we're looking more at $30 million, and that's just if an additional $30 million on top of all the money we talk about today that you're currently giving us. That would be today's cost if it just went in. We do know it's most likely it would be a lot more once you have that staffing minimum, because anytime you have a government mandate like that, the labor market goes, I mean, it would go crazy. The costs would skyrocket, and then our dependence on staffing agencies, I'm sure, would also skyrocket as well.
And you'd have to have the ability to find those nurses as well. May I continue? Thank you. Your $26 million estimate, is that including the payer side as well as the Medicaid side? So your increased costs? Yeah.
That would just be.
I mean, did that estimate come off of the total?
Did Kaylee say? I can confirm for you where, because we had our financial consultants give us that number.
Okay, and then last session, I talked to you about, I'm trying to think of the word, when the nurses contract to be a traveling nurse and say they go to Kansas City and they come back to Newton, there's a provision, and that's the term.
Non-compete.
Thank you, non-compete. Yeah. That bill, I don't think, went anywhere, and I don't know why, but it was to prevent these nursing contractors from putting that non-compete clause in there. So are we going to just, I mean, I know the prices are coming down, but not totally, but I think non-compete is a shame for people that do just want to come back home. And it would probably start solving some of our problems. So I would like to see, if that's still a problem, I'd like to see that, a little harder push on that next session.
Yes, we absolutely would be very interested in doing that.
Okay, and I have one more question, Mr. Chair, if I may. On your critical access nursing home model, I'm trying to understand that, because generally critical access hospitals are for short-term outpatient, inpatient, and then they move them on to somewhere else. So I'm not quite sure the analogy of the critical access hospital to the nursing home, because I would think you're thinking this in this situation, you're thinking of evidently money in the rural area, more money in the rural areas so that these folks will have a place to stay, which is not short-term. I mean, we're not going to just let them stay a night or two, right?
Correct.
Okay.
I think we're more interested in having a conversation of what that would look like. You know, for even within the Leading Age Kansas membership, we actually have a good number of critical access hospitals in our membership because they have long-term care units as well, which is a whole other confusing thing. And then those are now flipping to swing bed units, which is another confusing thing on the federal level. So it gets a little messy on short-term versus long-term, even within critical access hospitals. But I do think it is still worth considering what things we might, even if we don't call it a critical access nursing home model, but what things might need to be in place to preserve some of those services better.
And one thing I think to look at might be for those that are in crisis, you know, the dementia folks, and they just need a respite place for a couple of days. Thank you, Rachel, and thank you, Mr. Chairman.
Next is Senator Erickson.
Thank you, Mr. Chair. Thank you, Rachel. Always good to see you. Appreciate your testimony. Just a couple quick questions on the Medicaid add-on. If I'm reading that right, you're recommending that there be an additional payment amount for the amount actually spent to fill that gap. So no limit?
I guess maybe I didn't phrase that very well, did I? It was more about the reference to the add-on that you gave us last year was an average amount that we were able to calculate off the reimbursement formula with all the complex limits and cost centers that are in there. But even beyond that, through that process, we're able to see, and KDAD's reports on what the average amount of money is between what providers are spending on care on average versus what they're getting reimbursed. And so that added amount that you guys gave us was that amount. So it's not necessarily, the add-on you gave us even last year was not necessarily a matter of each nursing home just gets to decide on their own how much money they want to spend. It was still subject to what was going through the reimbursement formula and what was on average being spent and what that gap was.
Okay, and to follow up on Senator McGinn's question, if I'm understanding that 26 million correctly in my frame of reference, would you consider that an unfunded mandate from CMS?
It is 100% an unfunded mandate, yes.
Thank you, Mr. Chair.
Senator Fagg.
Thank you, Mr. Chairman. I've been through a couple of nursing homes, and each one that I went through mentioned something about $62 a month that the individuals get. And that hasn't been changed for a long time. Just wanted to see how your feelings were about that. Is that a state or federal? Because I know that's a net. They take your checks, my understanding. But they get $62 a month.
Yeah, that's called the personal needs allowance. And I think we all know that $62 a month, especially in 2023, is just extremely low. I don't want to give you a for sure answer and just be wrong, but I believe that is a state level thing that's set possibly by the Medicaid agency, but I'm not sure. That is for their personal needs. So I guess theoretically, what that would be based on of like why it's lower than you would guess is because if you're living in a nursing home, you know, you get your meals, you get all of that stuff, but you know, the nursing home isn't giving you haircuts. You have to pay for haircuts and shampoo and for new clothing. If you want your own special snacks and things that you're keeping that aren't coming from the nursing home, you have to use that on there. There's quite a few things that you think about that are your personal comforts, your individual personal comforts or hygiene that you might want to have for yourself, and $62 does not go a very long way.
Representative Carpenter.
Thank you, Mr. Chairman. Rachel, back to the real and property fee.
Yeah.
Paid in lieu of an allowable, and we went over this a little bit. earlier, David did, but I guess I didn't understand. So per day limit, is that of 1047, is that per, I mean, is that per client? Or is that, what is that?
It would
Is that just
be,
for your facility? So
it's your
that's
per diem for your Medicaid rate, so it would be per day per resident.
per bed? Okay, so $300 a month for each person that you have in your facility?
I guess it would depend on how many people you have in your facility, right? How many Medicaid days you're doing.
Just Medicaid?
Yeah.
So $10 a day. So if they were there the month, it would be $300.
Oh, I see what you're saying. Okay, yes.
So is that not correct?
That sounds like correct math.
I'm just trying to figure out if it's a per day or if it's per person, or is that what? I don't.
Yeah, so it's an add-on for your reimbursement, your per diem reimbursement rate. So it would be per day, per resident.
Okay. Thank you. Clear as mud.
Representative Haskins.
Thank you, Mr. Chair, and my fellow representatives stole my question, but I do have one more. But thank you for that. I wanted to circle back on the achievable quality incentives. Can you give me an example of what is a quality incentive? Like, what do something that I could understand in legislator term, I guess?
I know for sure they listed some of them in your slides, and then in Linda's testimony, I think she has the Candace Register. Does it have has the actual amounts and per quality incentive? So there's quite a few on there. There's
I can look that up.
yeah,
That's
but
fine.
they're really they're specifically listed in there for you.
Okay, and so can I get your opinion, if that's possible, about why, if we're taking care of individuals in nursing homes, why do we need incentives? I mean, why is that is it a competitive thing? Do I get a door prize or something? I mean, why? We're talking about those in nursing homes. We should not have to create incentives for them to take proper care.
So I think what a quality incentive is, and if you look at what it takes to achieve those, what happens is obviously there's a base good quality of care that everyone is supposed to be getting. The quality incentives are what do you call that? Is it on a curve? So they kind of look at all the different quality outcomes on these things across the state. And so if we have a member at Leading Age Kansas that's set in the curve and they're doing, I don't know, somehow 6 hours, just an example of 6 hours of staffing per resident a day somehow. They start setting that curve. And so it's a way to keep chasing higher quality. Does that make sense? And CMS kind of does the same thing with the 5-star system. If you have 5 stars in staffing, it's not a national comparison of everybody's doing it that way. It's you have a 5-star level of staffing compared to the homes in your area. And the better they get, the better you're going to have to get to do the 5 stars. And so CMS has that dynamic quality measurement as well. And you see a similar thing in our quality incentives, and that's how you measure them. So when I'm saying if the more Medicaid you take and the less adequate you're being reimbursed your costs, it's awfully hard to earn incentives when you're chasing people who are doing less Medicaid and doing presumably better on their financials and are able to hire more staff and do these things.
Thank you. That makes sense. Thank you.
Representative Bryce.
Thank you, Mr. Chairman. Thank you, Rachel. I've been thinking about something that you spoke about, and I think Linda before you spoke about, and that was the behavioral, dementia care, behavioral health, daily add-on payment as a way to fix that problem with additional costs with dementia patients and so forth. And I was just wondering, in my way of thinking, maybe you could answer this. Why is it not part of the case mix index of acuity of care? Doesn't that make them a higher acuity, and shouldn't it be addressed as an acuity issue in the formula? Or why was I guess my question is, why was the solution the daily extra payment? instead of
Yeah.
addressing the case mix index? Thank you.
I hope this is not just crazy speculation on my part, but it's been my understanding in talking to providers and some of these experts is that it's driven by the MDS, that assessment we do quarterly, and it only captures what the assessment wants to capture. CMS is the one that creates the MDS. They decide what goes into it and what's important. For CMS, they do Medicare. And so it makes sense that the assessment instrument they're doing is meant to capture what Medicare pays for, which is that acute physical need. Whereas long-term care, where Medicaid comes in, that custodial care, it has physical and acute physical needs, and you're meeting all of those, but it's also heavily focused on behavioral health and dementia care. And because under our Medicaid system, out of convenience and a lot of other reasons, we base so much of our stuff off on what's going on Medicare, it just kind of has not translated very well onto the Medicaid side when we're doing our state-based reimbursement.
Okay, I just guess my comment would be, it seems like instead of adding another appendage to an already confusing octopus of how we calculate this, it might be consider at least incorporating the extra acuity in the CMI. So that's my comment. Thank you.
We are definitely ready to work on any of those types of things and see what would be best, yeah.
Committee, further questions? I have one quick one. On your request, you were talking about a possible move to annual cost rebasing.
Yeah.
So you were just stating that maybe it's a possibility for KDADS to do
Some
an
more study on it.
analysis and see. So what things would you be looking for in that analysis? What metrics?
We would want to see how much more accurate we could get on cost reimbursement by going to shorter rebase periods. Because as I know you've heard from lots of providers, with the 3-year, you're looking back 3 years, plus our cost reports are always a year behind anyways. You're getting paid on money and costs you spent 4 years ago. That's a lot different than today, right? And so we would want to see if switching to that does a better job of accurately capturing those costs while also not causing too much volatility. That's what I hear about of if you go year to year. I suppose it is, I don't know how often it happens, we'd have to look at it, of maybe your rates are down here this year and your costs are down here, and then they go up and down from year to year. Your rates could go up and down, and it's hard to plan, right, for your budget. But the more we talked about it and more we've talked to providers in other states to do the annual rebasing, they really don't see that volatility issue. And so we would really like to do actual numbers here and do some modeling in Kansas. And the reason why we were cautious is because, of course, we don't want to just say, let's do this, and then it upsets the apple cart. And it can have really big repercussions for providers by messing around with some of those things. And so we just would really like to see some modeling done to see what the benefits would be to switch to that.
And in so doing, you would have them do what, a look back at the last, say, 10 years and see
Yeah.
how things would have stacked up, or how?
Yeah, Myers and Stoffer's is able to do a lot of that historical kind of look back because they've done our cost reporting and our reimbursement for so long. They're very good at being able to show us those different types of data modeling.
And theoretically, if we did enter a period of volatility year to year, how would your facilities react to that? Would that be really harmful, or would they adapt, or what?
I mean, they've adapted to many a thing over the years, but no, it would be very difficult for them, especially I think now when we're still in such a, so many of them are still in even though things are getting better, still in a precarious spot. And so I think that's why you're seeing such cautious language from us of like, let's do some modeling. Let's see, what would be a safe way to test this out and see if it would be better, because we don't want to not make these changes or innovate because we're scared of what might happen, but I feel like we can do it in a way that is cautious and as fact-based as we can to see what would work well in our state to make sure we're taking care of people the best we can.
Very good. Last call, committee. Questions? Representative Haskins.
Thank you very much. And so I did look up the incentive factors. Thank you for that resource on page 742. And so my question to you is, is the recommendation that if we continue with incentives and they have a value, when was the last time these incentive add-on dollars were increased?
I don't know, and I think what makes it difficult to determine, and is kind of one of the flaws we see in it as well, is that we don't assign a separate set of money aside from the Medicaid reimbursement that we ask for. So when the legislature gives us money for Medicaid reimbursement, it's a set amount. It's based on what Myers and Stoffers tells us would be necessary to hit whatever marker we're trying to hit. The incentives are not separately appropriated outside of that. They just take the big pool of money and then they kind of carve out this little part and distribute it to anybody who can earn it. And so we would really like to see a separate appropriation or some other separate formula or calculation for how we're really investing in the incentives, how effective we think they are, and how we're going to apply them. It just hasn't gotten very much attention at all in many a year.
I have one more, Mr. Chair, and then I'll be finished, I hope. So I'm looking at this and I'm trying to understand is like, here's the money, and we're going to take a % of that, and that's going to be set aside for incentives, is how you're.
I believe that's how they do it.
You're doing a great job. But then I'm looking at this, and it says CMI adjusted staff ratio is greater than or equal to 75th percentile. They get a $3 add-on incentive. Mm-hmm. That's in the register here. Mm-hmm. So how can we just give a % but yet also have these rates here? Because this is fixed, but you're saying that the % is not. Does that make,
Yeah, you you make lots of sense. I don't know. Okay. I think Myers and Stoffers could probably tell us if they try and just predict it based on year over year, on average, how much money have we spent on incentives. It may be that they fold that in and try to predict it from there.
But your testimony is it's not really an incentive. It's on paper.
To us, it has not been an effective way to incentivize that pursuit for higher and higher quality care.
Senator Fagg.
Thank you, Mr. Chairman. I was wondering, Rachel, sitting here, do you know how many nonprofit nursing homes there are in Kansas? We had a total number, but between profit and nonprofit.
Is it 110? I think it's 110.
110 nonprofit.
Yeah.
Okay, so when we were in trouble and we was losing these, was we having more trouble in one area than the other?
No, actually, we did look at that to see is there a difference between rural versus urban or nonprofit versus for-profit, and the last I checked, it was almost evenly split as far as closures.
All right, thank you.
Mm-hmm.
Okay, no further questions. Thank you.
Thank you very much.
Thank you, Rachel. Appreciate it very much. Our next conferee I would call is Dawn Vey. Did I say that correctly? I did. Welcome.
Thank you. Thank you so much, Mr. Chair. My name is Dawn Vey, and I'm representing the Kansas Adult Care Executives, which is a nonpartisan, nonprofit association for administrators and assisted living operators in Kansas. But we thank you so much for allowing us to comment, share, and be a part of this special committee that will review the nursing facility reimbursement rate methodology program. I am an executive director of a continuing care retirement community in South Hutchinson. We serve 230 residents on our campus. We do have skilled nursing and assisted living and independent living on our campus. And we serve 230 residents currently and about 335 during 1 year's time. And we've had such great presentations from Dave and Linda and Rachel that talk so much about all of the specifics about how we rebase and the methodology for setting things. So I don't really want to rehash a lot of that information, but want to focus on bringing information to you from someone who has their boots on the ground. And I have been doing this for 35 years. I started as a nurse aide in Kensington, Kansas, at a nursing home, and got my administrator's license while I was in college at K-State in 1985. So I've been doing this work my whole career, and I'm obviously very passionate about what we do. So I may make reference just a few comments from my written testimony, and then I will provide some other comments along with that. So in looking at the full rebase funding, which is on the bottom of the first page, the full base refunding of Medicaid provider rates is called for in the nursing facility reimbursement statute. Yet every year we have to come to the legislature to request funding that's outlined in the statute already. And it's oftentimes because it is not followed when the budgeting process happens. And so then over time, as some of the tables showed, our costs that are being reimbursed can range from 80 to 95% or 94% of the cost used to care for Medicaid residents. And never before in my 35 years have we had 3 years like the last 3 years. So it is kind of an anomaly, you know, in what we have been facing, but it's just has been such a short period of time. And when we use that 3-year rebase, some of the information is almost 4 years old, and that really tends to make a wider increase in the difference between the Medicaid rates and what our private pay rate residents have to provide. And when the pandemic started, our community had 96 residents in our skilled nursing, and now we have 68. So almost 30 residents in census that we have lost over those 30 years. Over those 3 years. Because of the fewer number of private pay residents, they are paying a disproportionate amount of the cost because of the continuous underfunding that has happened in the past. We have had to implement rate increases of 10% each year for the last 2 years in order to keep up with our costs. And this is approximately $1,000 a month. And so in the month of September, we just sent out for the second time where we did a 10% increase in rates. So that's about $30 a day. So those private pay residents then are paying $12,000 a year more based on our costs. Some of the other cost increases that we've had with the pandemic, staffing costs have increased from between 25 and 50% for various staff positions since 2020. We have been able to eliminate agency staffing in this past year. 1 year ago at this time, we implemented a $3 an hour increase in nursing staff wages. And that made a tremendous difference. The rest of the staff got about $1 an hour or a little more raise, and that enabled us to eliminate agency. And so within about 60 days, we hired 60 people in our building after we did those increases. And the facility has used agency even back into the 90s, and so to be able to eliminate that use has been tremendous for our facility. And just in the next week, we're going to be giving a raise to our staff members. That will be the 6th raise that we have given to staff members since January of 21. And that's how long I've been at the community. Our cost of supplies have increased from 14 to 60%. And just a couple of examples, one box of gloves has increased by 50% in their cost over the 3 years of the pandemic. And the dietary manager told me that a box of bacon has gone from $50 to $75 in purchasing that. So those are some of those issues. Next, in talking about the Medicaid payment add-on, we are so thankful for that add-on per day that more adequately reimburse providers. Residents who receive Medicaid represent a larger percentage of those being cared for than when the nursing facility reimbursement program was designed. And it's hard to think about continuing to lose money every day as we continue to move forward. I brought along my Medicaid rate sheet, so with all the different cost categories. And so in looking at hours, we're actually losing $12 a day in cost based on this cost report sheet. We have 45 Medicaid residents in our building, so if you take that times 365, it's $197,000 that we are spending that we are not getting reimbursed just because of the formula that's being used with that. And we do feel that really with this add-on, it really is just helping facilities to stay open while we continue to make adjustments to what's been happening. You know, with some of the things I've already talked about with the changes over the last 3 years, you know, even going from 96 residents to 68. There's a lot of changes that you have to, and adjustments you make with staffing in all departments. And with the added cost, you just have to be so cautious, and I'll address a little bit more in the incentive factors as we get farther into this. And they've talked about Medicare used to be able to cover some of the gap that we had when we didn't get all our costs covered by Medicaid. Then some of that funding came from Medicare. But now the increase in cost of medications and all of the treatments that residents are getting, now really studies are showing that with Medicare, we're essentially breaking even with Medicare residents. So now we don't have those extra funds to help make up for the Medicaid funds that we were not getting. And in our building, we do take residents who are on Medicare Advantage plans. And studies have just come out recently where about 50% of people are on Medicare Advantage plans, and we get paid about 20% less from Medicare Advantage plans than we get from Medicare. And so we average 2 to 3 people on Medicare Advantage, and that's even if they get approved to come to the building, because we do have some that don't get approved. And so some facilities do not take Medicare Advantage residents who are on those plans because of the loss, and that again reduces choices for residents in where they're able to go, and often makes them have to go outside of their hometown for services. The add-on also to us is helping a little bit with the physical upgrades and stuff that need to take place in our buildings. That's something that we're trying to work on, and one thing that we're going to do is actually remodel one room, get it set up exactly like we want our rooms to look, and then ask people or groups to donate funding to help redo all our rooms in that fashion. So it is going to be about $10,000 a room to do with new flooring and new furniture and things like that, but just want to do that to be able to provide good quality of life for the residents that we care for. Next, on the behavioral health, most studies show that about 50% of residents in nursing facilities do have some form of dementia. They do tend to take more staff time even than residents with physical needs, but as we've talked today, the reimbursement processes really don't take that into account. When we assess residents prior to coming into our building and then ongoing, we have to look at all the different types of care needs when we are looking at residents. And one of the things that does deter us is if in the hospital, maybe they had to have a one-on-one staffing situation, because we know in our building, we just can't provide one-on-one situations, or you might be able to do that for one person, but you can't do that for 10. And so that's something that we take into consideration. So I think this would be one of the good, if we had incentive factors, if there's some way to be able to measure the number of people in the building who have dementia or behavior issues, the higher the percentage, the more incentive you would have. Because with that not being included in the case mix, one colleague, talked about her case mix being about 0.87, but she has a lot of residents that they're having to provide one-on-one care for, but that's just not being picked up in the case mix numbers. And so now we are actually doing background checks on all residents before they come into the building because of requirements that we have in place to be able to provide care to those residents with criminal backgrounds. And it's because, like, if we would bring in someone who is a sexual predator to our building who had been convicted of that, then we would have to care plan to help protect any kids that come into our building from that person, and have it in their care plan, educate the staff, and do a lot of things. And so the same thing with if a resident had drug issues, then we would have to educate all the staff on what to look for in any side effects and stuff if that person might be using. And if we suspect that they have things in their room, then we have to call the police to have them come search the room instead of us doing that. So that's why we do background checks. And we have found many issues of residents being convicted of drug charges. And also then we have had actually a lot of inquiries for people who have attempted suicide also in our recent people that have been looking to come to our place. Moving on to the incentive factors, and I won't go over the numbers, and as you said, you found the table of the incentive factors here, and so from an administrator's perspective about the incentive factors, $5.50 of this pertains to the staffing ratio, staff retention, and contracted labor. Right now, we are so busy trying to make sure that we have staff coverage to provide appropriate care to our residents that this is not a consideration in our daily work. Once you decide on your staffing levels, you spend all of your energies trying to make sure positions are filled and your administrative nursing staff are not needed to work on the floor. So when you talk about these being incentives, for us to reach toward, I don't even pay any attention to, these staffing incentives because it's right now we're just trying to staff the buildings, so whether that's agency staff or whoever, we're trying to make sure things are covered. So it is a hard incentive factor for us to look at as something that we can advance towards. The incentive for having greater than 65% Medicaid in your building, that current incentive factor is 75 cents a day. And so when I calculated that for my building, it would give us $12,000 a year. If we were at 65% Medicaid. And right now, of course, with our census decreasing down to 68, we're not really asking a lot of questions when people are coming in. Our biggest question now is, can we provide care for you, appropriately versus are you a private pay person or are you going to be receiving Medicaid assistance? So it's not a high enough number if that's going to be, an incentive for us. And so I think changing the incentive factors to something that truly can make a difference and that we can actually have impact on that, like with those staffing incentives and stuff, our goal right now is just to have staff there and stuff. So, we've been blessed and worked really hard to make sure that we don't have to use agency staff in our buildings. But that doesn't work for everyone. It needs to be an incentive that we can all have impact on. I don't really have a lot of comments about the rest of my written testimony. I just did want to address a little bit on the development of the staffing mandates that have been introduced recently. So the overall staffing minimum numbers are not impactful to us as much. That's just a minimum of 3 hours per patient per day. And we actually already staff at 4.1 hours per patient per day in our building. But it is that RN coverage of 24 hours a day that's going to be difficult. And it's going to be cost and availability for that. For us to be able to cover this, we could have our LPNs go back to school. So they're going to need funding to go to school. They're going to have lost money from not being able to work. And then we're also going to have to provide coverage for them while they're going to school. So, you know, it could happen, but it would be very difficult. And thousands of RNs are going to be reaching retirement age in the next 5 years. And so even hospitals are already questioning now, because CMS has made this mandate or looking at a mandate for long-term care. Are they also going to do this for hospitals, have any kind of mandates for them? So it even could be something that impacts something bigger than just for us. As part of this mandate also is increase requirements for our facility assessment, which is something that we have to do. And part of that assessment is being able to look at our staffing compared to our resident acuity needs. And so we would have to have procedures in our assessment that show how we are going to adjust our staffing in our building based on acuity needs, which we do on an ongoing basis anyway, but for some, I mean, that's going to be an issue having that in there, and infection control and emergency preparedness. So, and just to finish, adult care homes remain financially challenged on labor rates and the cost of goods and services due to the lack of medical staff seeking employment and to high inflation of goods and services that are essential to operating an adult care home. Underfunding the nursing facility reimbursement program becomes an access to care problem for Kansas seniors, and the result is fewer jobs in local communities, and family members must travel farther to see their loved ones. Each time an adult care home closes, especially in a small community, Kansans have fewer choices to remain in the communities where they have lived their entire lives. CASE greatly appreciates the opportunity to share provider experiences with the committee, and we welcome the opportunity to be of assistance during future discussions about the nursing facility reimbursement program. Thank you for your time and consideration related to this future changing opportunity.
I assume you would take some questions?
I would. Mm-hmm.
Let's start with
Okay.
Senator Erickson.
Mm-hmm.
Thank you, Mr. Chair. Again, thank you, Dawn, for being here and for your presentation. Linda and Rachel both provided some staffing numbers for us, and I was wondering if you had any similar for your organization. For example, Linda said that their members care for nearly 20,000 elders and employ over 20,000 workers, and Rachel reported that their members serve more than 25,000 and employ more than 20,000 people across the state. So doing some Representative Carpenter math here.
Okay.
I'm wondering about the numbers for you, how many members and how many elderly people you serve, but also, is there a way to get a breakdown by staff member? How many of those are nursing staff? How many of those are administrative staff? Is there a way to know that? Because looking at sheer numbers, it looks about 1-to-1. So if you could comment on that, thank you.
Okay. And so our association is a little different. It is in that it really is a membership for the administrators and the assisted living operators. So we really don't do a lot of data with the size of communities and that, and it would really be more leading age and Kansas Healthcare, I think, who could probably get you better numbers and those things broken down in the community. I do know, just looking at our building, we're just doing evaluations. So I know the director of nursing got 90 evaluations to do. So 90 out of 165 staff are in nursing in our building. And I believe we have 13 nurses, licensed nurses, that work in our building.
I just think it would be interesting because the raw numbers really don't tell the story when we're hearing that there's staffing shortages around providing direct care to residents. And so that's why I'm wondering if we could maybe get a little bit more deeper dive into those numbers. Thank you, Mr. Chair.
Representative Carpenter.
Thank you, Mr. Chair. So we talked a little bit about this cost report. So you're not able to charge the full amount for administration?
Correct. And in CCRCs, which is kind of like my community, it's a little more complicated because like I, as the administrator, am over all the different parts of our community. So like my costs get separated out into the different areas and stuff. But there is going to be a limit to what can be used as a cost.
So when you're working on the floor or doing some kind of work that an actual employee would do versus an administrator, you're able to bill for that. It's just your administrative duties that you're not able to but put on the cost report at the full rate of pay.
And in limiting in some of those, yes, correct. Okay. And not all staff go into the direct care center, direct cost center. Like all your nursing staff would go into the direct care cost center. And I don't have all those details today, but.
It just seems to me like there's that administrative cost is necessary, even if you don't reimburse it for the full amount. You still have to have administrators, but that's just me. Licensing of your nursing home administrators. So you know the requirements of that?
Yes, you do have to have a bachelor's degree in an aging services related field. You do have to do 480 hours of a practicum in a community. Or it could be over a couple different communities. And then you do have to sit for national exams and then also a state exam to become licensed.
And you can hire them, but they have to get their license within so much time?
Yes, there are. You can ask for an interim license, and I believe that's for 60 days, and you can get that first and then actually get that done 2 more times. So that you actually could be an interim administrator for 6 months total before.
Bonnie, you know, we've worked on what it really takes to, and I'm not trying to belittle nursing home or anything else, but I'm just saying, how much experience do you need? Do you need a college degree, and then you need how many years of practicum experience?
480 hours, which is 12 weeks.
I mean, that's the kind of things that we worked on this whole year, and this one didn't come up. But this is one, I think, that we need to look at, relaxing those regulations down. I'm not trying to endanger anybody. I'm just trying to get folks in the door that may, you know, in rural Kansas, that could be an issue. And if they have a associate's degree or, you know, experience or anything like that. So anyway, thank you for that. And then Medicare, that's short term though, right?
Correct.
Okay.
Correct.
You were kind of talking like it was.
Correct, but yeah, but even, you know, and our average stay is about 20 to 22 days for someone on Medicare services. But in the past, those numbers would have provided you some extra income, you know, based on the cost. But now just with the increasing cost of, because when they come to our building in Medicare, the fee that we're paid encompasses all of their care. So if they have to have testing done or x-rays done or any of that, all is part of that as well.
Okay, very good. Thank you. Thank you for being here.
Senator Gossage.
Thank you, Mr. Chair. Just so that I could follow, you represent this, an organization, but then you said our facility. Could you clarify?
I was just giving some examples of things from my facility so that you could see what's actually happening to an individual facility in this. Because as administrators, our goal is really focusing on the licensed administrator and the things that they are dealing with. Yeah.
So the reason I ask
Oh,
is
okay.
oftentimes we will have a representative from an association, but they're not actually an administrator of one of the facilities, but you're speaking with both hats.
Correct.
That you are a member of the, and you also are an executive with one of the nursing homes.
Correct.
Right?
Correct.
Okay, great. And if I may, Mr. Chair, I'm so sorry that I had to step out, but I have a question for Linda. Sure. Is she still here? Linda, do you mind, just real quick? It says it here that you mentioned the trade association, and then you talk about assisted living, residential health care, home plus, nursing facilities for mental health. How many of those are state-funded nursing facilities?
In our membership, we only have about 5 that are non-Medicare nursing facilities.
Okay.
So, and they are not-for-profits, but for the most part, our nursing home members are Medicare certified as well as Medicaid.
So when you say 265 member communities, is this 265 centers? So if I take 5 off, it'd be 260 nursing facilities?
No, ma'am. We also represent assisted living and home plus.
So I guess the question I was asking is if we remove them from the numbers, how many of the state-funded nursing facilities do you represent?
We have approximately 170 nursing homes.
Okay.
And they're all skilled, but about 5.
Okay, that's what I
Is it-
wanted. Thank you. And the last thing is you said LPNs don't count. What do you mean by that?
In the CMS proposed staffing rule, CMS is looking at hours provided by RNs and hours provided by nurse aides. And they have studies that we don't agree with their reliability that discount the clinical outcomes of LPNs.
So if you were to turn in X number of hours, that, you know, we had this number of hours for a caretaker, let's say, and you include LPNs in that, you're saying they won't count those hours?
Correct.
Wow, I had no idea. Thank you so much. Thank you, Mr. Chair.
Senator Fagg, your question for Dawn.
Thank you, Mr. Chairman. Don, you had mentioned about nurse staffing, you know, that you'd raised 6 times since, was it 2020?
21.
So my question to you is, what's the total percentage? You know, were they just,
For nurse aides, I believe they went up 40%,
okay,
and nurses about 30.
okay, and if I may, Mr. Chairman, a follow-up to that, have you had a lot of turnover? You know, these raises going on, have you been able to stabilize your force? Because I know
We still have some turnover with that, and I will tell you a big difference with people from the pandemic and working for travel agencies is they got used to being able to work where and when they wanted.
Yeah.
And so now, you know, we have very few staff that actually work 40-hour weeks or full weeks. And it's people, as we just said, people are just unsettled. You know, just from my experience over time, it's just been a time of people feeling unsettled. And so that's been a big factor.
Committee, further questions? Representative Bryce.
Thank you, Mr. Chair. Dawn, I was going to ask you, Representative Haskins and others have brought up the incentive factors, and I was wondering, as an administrator and someone who represents administrators, if you had a magic wand, if you could change the incentive factors, what do you think would be the most valuable incentive factors for quality of care from your perspective as an administrator? Thank you.
I do believe that an incentive factor for behavioral health or providing care for residents with behavioral health needs is a big piece because that's something we can't get reimbursed through other ways. I would have to look and think more about that. I'll just tell you, in coming through the pandemic with things, we talk now a lot about trauma-informed care. And I can tell you as an administrator working through the pandemic, I have been traumatized in the last 3 years with that. And I just, I thought many days going home, I just felt numb going home. You didn't feel happy about things. You couldn't even be mad. It was just the days going into work and making those decisions and stuff. It was just a very difficult time, but I'll think of some incentives, so thanks.
Representative Haskins.
Thank you, Mr. Chair. And I'm glad that you emphasized, incentives based upon behavioral purposes to improve. I wanted to circle back on that because during that presentation, you talked about background checks. And it came across as like screening your patients. And I was could you give us, are these just criminal background checks or financial? What are we doing?
It is just a criminal background check.
Right.
And it's one of the free ones that we can access online. And it really is just because there's so much preparation we would have to do if we brought in one of those residents in our building.
Yeah, that makes sense. And so thank you for that.
But we've just been surprised at what we've seen when we do those.
Senator McGinn.
Thank you, Mr. Chair. Hopefully this is a quick question, but I thought I heard you say at the beginning of your testimony about Medicare Advantage and trying to get them on that. Did I hear correctly? Were you talking about that?
Well, with Medicare Advantage, it's hard to get Medicare Advantage to approve them to come to a nursing home. They often decline people to be able to come.
Medicare Advantage does.
Plans, correct.
Okay, thank you for that clarification. Because I know in the hospital world, it's, they're overselling what they're providing. And
because,
even
with discharge planners, they count on us to try to work with the different plans to try to get people approved. And usually if they get approved, it might be for 7 days, and then you have to send in more documentation, and you might get approved for 3 days. And
I'm glad I clarified that, because I was thinking you were wanting those plans, and it's okay. So you're in line with the others.
Correct.
Thank you.
Correct.
Senator Gossage.
So one last clarification on that. For someone who writes Medicare plans for seniors in Kansas, there are the D-SNP plans as well, and those are for people who are preferably we're talking about nursing homes or nursing facilities. So if someone's in a nursing facility, they could get a Medicare Advantage plan that's aligned to go with. On a long-term basis, that would add things like dental and vision and out-of-pocket expenses and over-the-counter stuff that they normally wouldn't have. You're not referring to that.
Some of those other pieces, are covered. It really is just like
it's
for
only
a
in
Medicare
the short-term part. Good to know.
Correct.
Thank you.
Correct.
Further questions, committee? Seeing none. Thank you, Dawn.
Thank you.
Next, I would call David Kingsley.
Well, good afternoon, and thank you for the opportunity for us to speak here today. My name is Dave Kingsley. I represent the Center for Health Information and Policy. We're a 501c3. A little bit about us. I'm not sure how you define seniors, but we're all seniors. In fact, if we call the old 80 is old, then I'm old. But we've all had a fairly long career in something or other. Many of us are former academics. We have professors and business folks that we've come together in a network, which is pretty much across the whole United States, to look at the economics and finance of aging programs. We focus a lot on the long-term care and skilled nursing. I've probably spent hundreds, I can't count the hours, looking at thousands of cost reports over the past few years, and I want to talk about cost reports to you today. I know it's been kind of mind-numbing. This gets really in the weeds for you, and hopefully we can make it a little more interesting. And I want to say I'm more interested in the overall structure, the legal and financial structure of the industry. I'm here to talk about the industry, not about the nonprofit, but the for-profit. We've seen a huge sea change in how the industry has restructured itself since about 2000, and I'll talk about that a little bit. But one thing I do want to say is if you've seen one nursing home, you've seen one nursing home. If you've seen one nursing home chain, you've seen one nursing home chain. If you've seen one state Medicaid program, you've seen one state Medicaid program. For instance, Kansas has an average bed size of 60, which is very small because the national average bed size of nursing homes is 100 beds. I did a fairly large project for New York. We have all of their 2020 cost reports in a spreadsheet. We reported our findings to the comptroller of New York. We've done the same thing for Kansas recently. We now have all 2021 cost reports in a spreadsheet, and we're looking at that now, and I can share some of that with you. But when I say, you've seen one nursing home, you've seen them all, I do think it's good to get out and look at examples. And I'm going to talk about a nonprofit. When we talk about the PEAK program, we know that the model for the PEAK program is Pleasant View and Inman, Kansas. I don't know if anyone here represents that part of the state, but if there's a nursing home that any of us would want to go to, I would say it would be that one. And if we consider that the model in the PEAK program, everything below that is a long ways below that facility. It was a facility. It's actually a continuing care form of organization. And it was 5 churches in the community of Inman that came together to start that facility. And I'd heard so much about it, talking to folks around the state, that I went out and visited. I had spent a day there, and you're seeing a nursing home with private rooms. People have their pets. You go down to the kitchen in the morning, whatever time you want to get up, and they will fix you something to eat. They have a little restaurant attached. You can go to their little restaurant and eat. That's what we call the home culture. That's what the PEAK program is supposed to incentivize. I'm not sure that's happening. I find it very difficult to get information on the PEAK program in terms of how it's evaluated. And I think that's a problem that I'm going to talk about today in general is what we call transparency. I work in many states. I work with advocates all over the country. And if there's one thing that the advocates are asking for is transparency. And we can talk a little bit about what we mean by transparency. I did want to mention real quickly that getting into the minutia of reimbursement, as mind-numbing as it is rather important, and the move from the RUGS 4 system to PDPM is something that I think we should look at, but I'm not going to get into that today. I have been talking to Illinois And they've been there for a couple of years, and we should see how that has worked out. I talked to Andy Ellison the other day, and he said they should have some evaluation of their PDPM coming up. But what I would like to talk about today is how do we price? You know, when we look at cost reports and we look at costing this service in Kansas that the taxpayers are paying for, it's what we call a facility-specific cost-based method, which means the facilities report what their costs are. And we see what their costs are based on what they put on their cost report. So they'll have an income statement, and we know what their net operating revenues are. Their net revenue and their net operating expenses, and then we see a net. And the net income of nursing homes is going to be a wide variance. One of the problems I have is Clifton Larson and Allen publishes a report every year. It's a large accounting firm, and so, well, we have an average net income of a negative 0.5%, a +%, and they put a median up, and they're talking median on a bar chart, which is not the way you represent statistics to begin with, because what we're seeing in this industry, and what I told the state of New York was, if you have a system and you're monitoring and controlling that system, you should be able to reduce the variance. I just looked last night at Kansas. I pulled out all the facilities that had a net between -30 and +30. That's percent net, based on what they had made after they expensed their costs. And there were 165 facilities. So that tells me we have 275 facilities, by the way, in our spreadsheet. So 165 facilities. We were able to narrow that only down to -30 to +30% net. That really is something we need to look at, because net income isn't really telling us what the facility is making. Okay, it's not profit, number one. Number two, there's no private facilities, for-profit, that I know that are not part of a chain. When I talk about the transformation that we've seen in this industry since 2000 is the mom and pops went away. They've been bought up, and I can talk for hours about the chains in in Kansas, because I've spent years following up on ownership, who owns the facility, where do we trace the money to? And I would be hard-pressed to find any facility today in Kansas that is a mom-and-pop operation, number one. Number two, I would be very hard-pressed today to find a chain that is owned by a Kansas corporation. And I'll talk a little bit about where that money's flowing out. But one thing that's happened in this industry is it's become what we call financialized. We've seen the entry into the nursing home business about 2000, because there was a huge amount of free money, a lot of capital pulling up in various funds, whether they're sovereign wealth, pension funds, whatever. So we saw private equity research, and we saw private equity come into the nursing home business big time in the early 2000s. We also saw real estate investment trusts come into the business big time about 2000. The real estate investment trusts and the private equity firms work hand in hand. To give you an example of how that affected Kansas, in about 2007, the Carlyle Group bought the HCR Manor Care chain for $6 billion. It was about 2012, they sold all the property for $6 billion, and that's basically what happens with private equity. They essentially bankrupted HCR Manor Care. We had some chains that had built up since you can date the nursing home industry to 1950, when the federal government began to authorize federal payments to providers. By 2000, we had the Beverly Enterprises, we had the Genesis, and we had the HR Manor Care. They were the big chains, along with all the small mom and pops. Those big chains were bought out by private equity. They've been split up, sold off. A few of those ended up in Kansas. The HR Manor Care were picked up by a criminal enterprise, about 15 facilities, the Schwartz family. They essentially pocketed money and ran off and bankrupted those facilities. They went into receivership. So now, today, the biggest chain in Kansas, the biggest chain Kansas has ever had within the state, are the 27 facilities owned by Community Mission Health. Or not, let me back up. They're not owned by Community Mission Health. They're managed by Community Mission Health. That takes me to the point I want to make today, and what we really have to look at, and I'll get into some specifics on cost reports, is it's widely believed that Community Mission Health does own these 27 facilities. And if you look at on my testimony, my written testimony, on page 7, you'll see a schematic. We've listed all of those Mission Health facilities. I apologize for sort of the small print there. Community Mission Health, Mission Health Communities is in the portfolio of Windward Health Partners, which is a private equity firm. The private equity firm is capitalized by an investment bank in Tampa Bay, Florida, called Skyway Capital Partners. Skyway Capital Partners is really the owner of these facilities. One of the things that we need to really look at is the property, because what I say about this industry, it's got 3 prongs. It's got healthcare, finance, and real estate. This is a real estate business. So what we've seen happen over the last couple of decades is a separation of property into a separate LLC. That we call that OpCo-PropCo. So the facility is paying a lease payment to a subsidiary of the parent company that owns the facility. In other words, the facility is a subsidiary set up as an LLC. The property is a separate LLC. What that means is the facility is leasing on a triple net lease, by the way. I want to make that clear. A triple net lease means that the leasee pays insurance, taxes, and maintenance on the building. All the maintenance on the building, depending on how the lease is written, but it's in this business, triple net leases are standard. So that separating the property was a big deal. All the properties separated. It's very rare to find nursing homes now where the nursing home is operating out of a facility where the facility either is paying on a lease, or on a loan, or they own the building, that they have full equity rights in that building. Other types of innovations we've seen, and by the way, I would say we've seen amazing financial innovation in the nursing home business. We've seen very little innovation in care. The Pleasant View is a real innovation in care, but we still pretty much across the board have what we saw in 1950. I visited a nursing home in Van Nuys, California in 1970. It was very much what we look like today. I can give you another example of a nursing home. I think it'd be a good idea for this committee to take a field trip and visit nursing homes and see the diversity. One nursing home I was in recently is located at the northwest intersection of Roe and Indian Creek in Kansas City. That building looks like a really upscale resort. It's a beautiful building. You go inside, it's beautiful inside. It's got all private rooms, but they only take Medicare. They are licensed by the state of Kansas to provide, but they don't take Medicaid. And we have other facilities like that I could talk about. That is owned by a Colorado corporation, and when you look at the property, look up the property, you'll see that it's increasing. The market value of that property's been increasing. The assessed valuation on and in the county database. And by the way, that's what we are finding, and this is going to be one of my recommendations. If we really want to know how the capital flows through a particular chain or through this whole industry, it's a very laborious task because we have to go into the county database to see who owns the property. And sometimes that's pretty difficult. It's easy in Johnson County. Wyandotte County have very easy access to their properties in their database. Then we see an LLC. Typically, an LLC is going to own that property. Then we go to the Secretary of State to find out who owns the LLC. And you really can't find the owners of an LLC very well on the Secretary of State's database, but you see names, you see addresses. That's one way we can connect the property to the parent corporation. Otherwise, we really can't do that. So one of the things that I really would like to see is that we look at legislation in the state of Kansas that we require transparency. We require that the parent corporations report their consolidated financial statements, just like you would if you were a publicly listed corporation. That would be an income statement, a balance sheet, and a capital flow statement. If we don't see that, what we can't see is if there's a negative net income at the facility or a low net income or any net income, that really isn't very meaningful to us if we can't see what the parent corporation is showing on their income statements, because that's really how the profit, that's where the profit shows up. And that's one way, by the way, we're going to determine whether we're pricing this, whether it's being priced right, whether we're paying more than we should. Let me give you an example. The biggest nursing home chain in the United States was not formed until 1999. That was the Ensign Group. They're located in San Juan Capistrano. We have 6 of their facilities in Kansas. They've acquired about 5 of those very recently. They're rapidly growing. I happen to be probably the expert on that company outside of somebody in the company. I've just published a paper with my colleague, Charlene Harrington at the University of California a couple of years ago, where we traced the development of that company since it was formed in '99, issued an IPO in 2007. It is the only large nursing home chain in America that's publicly listed. In fact, it's the only publicly listed nursing home chain in the United States. All the other nursing homes chains are closely held. That's why we can't really see if the dollars extracted are appropriate to what we're getting. In other words, what is the bang we're getting for the buck based on what we could see? If we look at the Ensign Group, I just looked at their 2022 10K. They had a net income of, I think it was 7.5% net income, which is robust. That's good. They had earnings before interest, taxes, depreciation, and amortization, what we call EBITDA, which is really far more important, of about 13%. So that's a very robust earning for a corporation of any size. And they're about a $3 billion corporation. We hear that the nursing home industry is going to is in trouble. They're running on a thin margin, and so forth. But when you look at where we can see, and that's a good example of where we can see a 13% EBITDA, plus their revenue in 2021 was 2.6 billion. It was 3.2 billion in 2022. So they're rapidly growing. And that may be something we have to look at in this industry is market consolidation. Because if we got 27 facilities now in Kansas in one company, which we've never seen before in this state, then that's telling us we're going to see that happening. So the big fish may be eating little fish is basically what I'm saying. I did on page 2 of my written testimony give you an example, and I want to talk a little bit about cost reports. And I look at cost reports practically every day. Looked at huge numbers of cost reports. We've entered cost reports in our spreadsheets. But what I was trying to show you in that table on page 2 is, this is where we need to look at the parent and the holding company and what they're taking out of the business. On the cost reports, we have a form that indicates related parties and home office allocations. I didn't want to bring a lot of forms in. I've given you an example, and I'll go over that in a little bit. But the Ensign Group has these 6 facilities in Kansas, and what I'm trying to show you on that is they had $57 million, $57.2 million in revenue from the state of Kansas. They're showing a negative net operating income of 1.9 million and a negative net percent of minus 3.4%. But they had sent $8 million, $8.3 million of their $57 million in Kansas revenue to their holding company in San Juan Capistrano, i.e. Ensign Corporation. And so they had sent 14.6% of their revenue either to their home office or to related parties. Now, related parties, by the way, are not just property. We're seeing related parties more and more for insurance, where these corporations are setting up their own insurance companies. If you look at Ensign Group's cost reports, you're going to see their home office allocations, which are huge. You're going to see their property related party expenses. And you're going to see 3 insurance companies. You're going to see an insurance company for workman's comp, liability, and health. And this is something that really concerns me. I've talked to accountants who are really knowledgeable in this area, forensic accountants. We're seeing insurance entities set up by parent corporations, and they have to be building up pools of capital. And we don't know where that capital is. Is it in the Cayman Islands? Is it where is it? How much is there? What are they earning? But what I see that as a way to leverage Medicaid and Medicare dollars into far more than what they're earning just providing Medicare and Medicaid services. I think we have to keep that in mind and really take a hard look at that. Another thing that on the cost reports that, and by the way, there's a lot of flaws on the cost reports. There's a lot of misinformation, no information, wrong information. The Ensign Group, even though they own or manage 300 facilities across the United States, they have those arranged in 500 LLCs, all incorporated in Nevada. So what you're going to see is these LLCs that are set up as related parties are going to be incorporated in states like Delaware and Nevada, where they have far less liability. They're able to, their capital flows through there are far more secret. And the taxes in Nevada, the corporate taxes in Nevada are going to be, I don't think there are any corporate taxes in Nevada. So Nevada has kind of become the Cayman Islands of the United States, by the way. It's kind of how we look at that. So I think it's important to look at these kinds of companies coming into the state of Kansas or already here. I can name the big entities that are operating here. Life Care Centers is another one. They have about 6 or 7 facilities, but they're one of the biggest in the United States, but they're owned by one person by the name of Forrest Preston. I will just real quickly point out on page 3, I did a little schematic of the Riverbend facility. That's an Ensign group. It's in Kansas City, Kansas. It kind of became a poster child early in COVID for deaths from COVID. I think they had 30 deaths quickly from COVID. Nobody knew who they were, hadn't heard of them, but they were in a Kansas City Star. I have several articles out of the Star on them. And you can see this may or may not be totally correct, this flow chart, but I think it's pretty close. We have the money flowing from Medicare, Medicaid, private pay into the facility. The facility's paying out to Little Blue Holding LLC. That's a real estate. I've listed their insurance liability, health, workers' comp. You'll see Endura Health, that's a shell company. All of these facilities are set up for the capital flow into a shell company and then into the corporate headquarters. And that makes the flow of data or the flow of capital very opaque. And that's what we're dealing with. And I think that's what I'm here to ask you to do today is to begin to look at what California did and other states are considering is legislation requiring more transparency, which would be the consolidated financial statements I talked about. And I also have included in my recommendations not just a consolidated, I'll refer you to page 4, is that we require audited financial reports. I want to use the word audited, as I just mentioned. And we need to really look at their home office allocation claims. In other words, how are those justified? The law on that is very sketchy. Basically, the law is they must be reasonable. But I think we need far more detail on how they're going to justify those home office allocations. Plus, we need to look at how they justify the lease they're paying. When you look at little communities around Kansas, you're going to see the properties are going to be $250,000 to $300,000 to $400,000, and that's a pretty low value for a nursing facility. Versus, say, in Johnson County, it might be $3 or $4 million property. Is the lease payment to that property, is that entity charging an appropriate lease for the market that they're operating in? In other words, what is the going commercial rate for that kind of property in Downs, Kansas, or in Pratt, Kansas, versus what they're being charged? Are they being charged the same lease payment they are in Johnson County, let's say? I will say this, that I track stock in these real estate investment trusts, and I haven't even gotten to the real estate investment trusts because they're existing. You can't see them. I tracked one down that owns a property in Kansas, but you wouldn't know that by going through all of the Secretary of State's database and so forth. So what can we expect in terms of transparency? Let's see what else. I think another form of transparency that we need to talk about is, in property, when that data changes And by the way, I see this industry at the real estate component of this industry, which is huge. This is a big real estate industry. And by the way, real estate investment trust, the healthcare and real estate investment trust are a going concern these days. And the real estate investment trusts we find in nursing homes are Welltower, Ventas. You may have heard of some of these. They're doing much better these days than commercial office space. I've tracked their stock since the market tanked a couple years ago. They're doing fine. By the way, the Ensign stock was 75 in late November 2020 when the market began to go down. It is appreciated about 25%. Also, when you look at who really owns the Ensign Group, like most stock on the exchanges, it's a Vanguard, BlackRock. BlackRock and Vanguard and Wasatch Advisors own about 45% of the Ensign Group. About 90% of the Ensign Group is owned by asset managers. So that means that this industry is attractive to investors. And that really tells the story about the growth of community health mission health communities in Kansas. So I just want to point out the kind of flaws that we see in these cost reports. If you go to page 6, and I apologize, that's a fairly small print, but that's an example of the form that we get on cost reports. This form should include a home office allocation. It should show us what related parties, the entities, whether it's real estate, whether it's health insurance or whatever it is. This only shows administration and general management fee, and you've got they were approved for $219,000 approximately. This facility is in McPherson, Kansas. McPherson operator. That's one of theirs. Well, and then at the second part of that form, they're supposed to show who the owner is, and they're showing Mission Health Incorporated as a 100% owner in the home office. See, that's false because I gave you the schematic on the prior page. Mission Health Communities is in the Windward Health Partners portfolio. They're a portfolio company that have been set up to manage. So they really should show up as a related party on this because they're getting paid out of the, as an expense. They're not the owner of the facility. So, you know, I could probably stand here all day and talk to you about the kinds of flaws like this, what we're seeing on these cost reports, which keeps us from really understanding who's getting what. And we've got to really take a look at that. With that, I hope I've helped enlighten you somewhat about this industry. But like I say, I'm looking at up here, and I understand the minutia of trying to reimburse at the state level. But and that's an important job. I've known Dave Halferty for a lot of years. Dave's very helpful to me. He's always a good guy to talk to. I think the folks working in KDADs in the government, they do an excellent job, but I think the issues are beyond what we're talking about in terms of incentivizing, in terms of how we come to some sort of a decision on what we're going to pay for what we're buying. And I think that's, you know, if I could look at this whole industry and make a suggestion is, let's quit doing cost-based pricing and let's price it based on what this is worth, not on what the industry is reporting. And that's how it really basically works, is the industry reports what their expenses are. And then we come to some determination as to what we're going to pay them. But that doesn't tell us if there's transfer pricing going on. That doesn't tell us if we're paying the right price for property, health insurance, and all of those expenses that they're expensing. All right. So if you have any questions, I'd be happy to answer those for you.
Thank you. We'll start off with Representative Epley.
Thank you, Mr. Chair. I really appreciate it. And gosh, I appreciate your in-depth testimony, David. It's, believe it or not, it's kind of an eye-opener. I learned some things and I didn't realize. I think on your testimony, on the page, it shows the net amount that the parent company is taking out of the, I can't find it now, on page 2. That's just I don't know if that's pretty accurate. That's kind of a stunner. So, we saw the same thing happen with some hospitals in Kansas, also with a holding company that was based in Kansas City, but the parent company was in Florida and actually closed 2 hospitals that I'm aware of. So, that same situation is now infected, if you will, in the nursing home industry. And I guess my question to you is, do you think that you're not thinking we should abandon the method of reimbursement right now, but that we need legislation or we need policies that absolutely flush out all the data and the transparency from the holding companies and the parent companies in these situations? Is that what you're giving us direction to do?
Yeah, absolutely. I don't think we could even imagine right now saying, well, we're not going to do this kind of reimbursement now, but I think we need to begin to at least modify it by looking at cost and price economics. In terms of economics, how do we determine an appropriate price for a property rather than taking the cost report expense for that property, just the lease we're paying on that property, and not looking at if that's a triple net lease, what is the entity we're paying it to? Because that's a good deal. A triple net lease is, if you can pretty much then figure that your net operating income on that property is going to be pretty good. So I think we need to look at that and really begin to ask, are these prices appropriate? Now, if these corporations are making pretty good money, well, how do we square that with the hardship pleas we're getting?
Sure.
And that's another issue, by the way, is when we try to reform this system, the industry is going to come back and say to us, we can't afford it because we're running on a low net. We've got a thin margin. But that's irrelevant because those margins and nets are the facility.
Mm-hmm. I want to just one step further. Thank you, Mr. Chair. In layman's terms, by triple-step lease, it appears to me that you can legally cook the books. I mean, to put it in terms I can understand it, that's how it appears. Is that correct?
Yeah, oh, absolutely. And I want to say that in my view, I spent a career in private industry, big corporations. And if we had a turnover of 79% or 50%, we would have fired our managers. We have to ask ourselves why we have a labor problem in this business. That we have a labor problem because this is a financialized business that's in short term. In other words, you get in, you get out your property. Some businesses endure, but it's part of the business model to you expect your turnover to be high. And so we're not seeing a reinvestment for long-term growth in the business because there's so much churn in the property. Gotcha. And churn in facilities, chains being bought out, and that sort of thing. So I think if you invest in your workforce, and I know our spreadsheet, I've been working on that. We're seeing about $16 on average per hour. Now, there are some facilities that will pay $24. That's very rare to see for a CNA. But $16 an hour is what they're paying workers to work at Cinnabon and Annie Ann's in my neighborhood. Okay? So you've got a $16 an hour person taking care of very sick people.
Thank you for your testimony. Thank you, Mr. Chair.
Senator Fagg.
Thank you, Mr. Chairman. Thank you for your presentation. Whenever one of these places are licensed, do they get financials on these?
Pardon me?
Whoever's getting a license for a nursing home today, do they turn any financials in at that time and somebody review those?
You know, I have looked at that law. I think that's a requirement, but I'm not sure. I don't have access to the documents. I wish we did. I mean, I think the public should have access to all of those documents, and maybe we could get them to see. I mean, how did Joseph Schwartz come into Kansas and get 15 nursing homes? You know, and what I found was he had defaulted on a $90 million loan. So he had leveraged that. Now, here's another one, Diversicare. They have 6 facilities in Kansas. Diversicare is a chain of about 60 nursing homes. They were public. I was watching them on, they were booted off the NASDAQ. They were sold over the counter. But a guy by the name of Ephraim Lahaski bought that chain and took them private. Ephraim Lahaski could not get a license in Vermont. They would not give him a license because his reputation was so notorious. And I can tell you in all my experience, I have never seen a state say, we're not going to give this guy a nursing home license because we know what he's done in Pennsylvania. He now has 6 nursing homes in Kansas. And he got that after Vermont had denied him a license. So I think that could be a problem in terms of, are we really looking at, although I don't believe that people, investment banks, groups with money that want to buy nursing home chains will have any problem meeting financial criteria that they need. In other words, they're solid financially. But sometimes their reputation precedes them.
Committee, other questions? Representative Haskins.
Thank you, Mr. Chair. And I just wanted to circle back on page 2, that table. And just for clarification, that net patient revenue, is that the amount that the state gave, or is that?
Right.
Okay.
If you look at the cost reports, the income statement, and this is another question I have, is you'll see what their revenue, they'll give you a revenue number. And then they'll give you a contract allowance. And then they'll give you net patient revenue. It's the net patient, because I can't even find out anybody who can tell me what the contract allowance even means, you know. So that's what they've made. That's what they've been paid for their Medicare and Medicaid services.
Okay. And then how did you determine the home office related parties amount, considering that the cost report that you gave was very minimal? I mean, is this just deep dive into, how did you determine that?
That comes off the related parties form, the one that I have attached here for this Mission Health Communities facility in McPherson.
Right.
That should all be shown on that. What you'll see, and I'll give you an example, Representative Haskins, I'll give you an example of what the Ensign Group, they all look alike. Their cost reports are uniform all over the country, and they're going to show 3 or 4 different forms of home cost allocation up on the line 1, 2, and 3. And then they're going to show each of their health insurance companies, their liability, their health insurance, and their workers' comp. And they might show some capital-related cost on there also. So that's how I took that off of there.
So in this case, for these companies, there were actually cost reports that you gave that you could use. Yeah. Okay, and then now you're saying that all those reports for all these companies, they're just uniform. They're the same, except the amount may change. It's like, so if we own you, you're going to have to pay this, this, and this no matter what, because it's just standard in the cost report. Is that how it comes
Well,
across? or-
their amounts that they're showing for their different entities may vary across the
Right,
country.
the amounts may, but the categories itself, it's going to be
Yeah,
the same.
it looks to me like they're going to take about 14 to 15%.
They're getting their piece of the pie no matter what.
That's going to flow directly to their up the ladder.
Through a
Now,
shell
I will
corp
say
and then-
this, we don't know what kind of money they're making in those those insurance companies, or what their net operating income is from the facilities. And there's one other thing I want to say is labor contracting. I didn't get into that, but we got to get into that because I don't see much labor contracting with the Ensign Group. But I'm seeing a lot of labor. About 5% of Kansas labor was labor contracted. And I'm wondering if that might not grow. There was a facility I found, and I was blown away because their LPN rate in 21 came up to $8 an hour. I'd never seen anything that low. So I checked out the facility to see if we had a data entry error, and we didn't. That's what was on the cost report. But they had a lot of contract labor. This was in a little Kansas town. They had a lot of contract labor. I found out that it was a nonprofit, but it was being managed by an outfit that manages nursing homes around Kansas, usually nonprofits. The management company owned the contract labor company. And that's how we trace that back. So that's something, that seems to me borderline illegal, or at least a major conflict of interest. And if it's not illegal, we should make that illegal. But if you can buy, you can pay your own company for property. I guess you can pay your own company for labor. But I think those relationships should be looked at. But it was interesting to me that $8 an hour CNA would be working beside a $32 an hour labor. Well, I don't know how much the labor contractor took off and how much the CNA was. But when you look in labor contract in nursing homes, it can be kind of attractive if you're a CNA or an RN because you're going to make a lot more money. Now, whether a person wants to travel around and take that job, but it seems to me that's a problem because you got people working beside each other that may be making a lot different amounts of money. And that will create a labor problem, I think.
Representative Carpenter.
Thank you, Mr. Chair. Dave, thank you for being here. So in this, again, this table 1 here, we're looking at this net patient revenue. So you've been able to divide the private pay out of that?
Yeah, it's very easy.
This is only Medicaid
It's
or
very easy.
Medicare?
Right, what we should do is have a meeting and just show you the cost report forms.
And that's kind of what I'm getting at. You've made, I think, an enormous bunch of accusations here in a public setting that I'm not sure, we have your word for it right here in this piece of paper. I think that's just something we should be very careful about, making that kind of accusations about an industry or a group of people or anything like that. And it's pretty one-sided, don't you think? I mean, we could have them in too, if we had a real meeting, we could have them in as conferees or,
sure,
and then it would be,
sure,
maybe there's some explanation. I'm not defending these folks at all. I'm just saying that, and this is kind of alarming to me. How many nursing homes in the state of Kansas are owned by corporations?
Except the nonprofits.
By these large corporations?
They vary in size. I mean, I could tell you, let me answer your first.
But half of them in our state?
I need to speak to one thing you said.
Okay.
That every piece of data on here came off of their cost reports.
Okay.
That's what they turned into the state of Kansas. And I'll show you those. I have one.
That's fine. But we're in a public setting and we need that proof too. But again, how many nursing homes are owned by these large corporations in our state?
By large corporations?
By half, are they half? I mean, of these entities you're talking about?
You know, I can't give you an exact number. You know, we have small chains like Advena. Then we have the life care centers. We have the Good Samaritan, which is a nonprofit. That's a large chain.
But just give me a number. We've got 300.
I can't give you a number.
Okay.
Yeah.
So all I'm saying is that these are corporate whatever, and they're making this large amount of money, but we have small mom and pops and smaller chains and stuff like that that we hear all the time are struggling. So I'm trying to figure out, these guys are raking, these guys, one group is sitting there going, we aren't making it, we're barely covering our costs. And then you come in and these guys are getting rich off of their nursing home operation. It just strikes me as kind of odd.
Is that any more one-sided than the industry coming and saying we're not making money when they are? With what they present with Clifton Larson and Allen report?
I haven't seen that report.
Well, I've heard,
So,
I've heard
again,
KCA.
this is back to what I'm talking about.
Well,
These
I've heard the industry come in here and talk about it, Clifton Larson, now not to present it to you. I'll give you these cost reports, every one of them, will support every piece of data I have on here.
And
I
that's
promise.
great.
Yeah, and what I'm talking about here, I don't think I'm not generalizing to every nursing home chain, but I'm saying that this is the tendency we're seeing in the business is the Ensign Group is growing rather rapidly. And then we have some smaller chains. If we can see their consolidated financial reports, why can't we see them? If they're saying they're not making money, show us the books. Show us the money. If you've got public stock, you're on an exchange, you have to send in a 10K. And I don't see why a corporation that's all of its revenue practically is coming from the taxpayer shouldn't be willing to show us or should show us the same thing. That's what I'm saying.
So is that across the board then? Anybody that gets tax dollars or public dollars should just open up their books?
Yes.
Okay.
Yes. Because I don't even consider this a capitalist enterprise. Because it's fully, it's not a free market. This market is based on a certificate of need and getting a license. And at that point, the market then changes from a free market to a controlled market. This is really a government corporation collaboration. This is not really capitalist free enterprise, what we're talking about here. And yes, I believe corporations, whether they're United Health and doing the MCOs, of course, we know we can see United Health 10K because they are public. But any corporation that is fully funded by the government should show us the books. We have a right as taxpayers to see that.
Thank you. Thank you, Mr. Chair.
Senator Gossage.
I'm so sorry. I was reading along with your testimony, Dave, and thank you for being here. And so my questions are, isn't this a privately owned nursing facility? These are all privately owned nursing facilities. So they're not state funded. Yes, they have some people, patients there that are receive Medicaid services. And so therefore, the patients they were reimbursed for those patients for those Medicaid services, but not considered a government-funded entity. It is a private entity, right? Just like you have a private hospital, and maybe some of the people that go there pay with private insurance, others are cash payers, others are on Medicaid, others are on Medicare, but it's not a state-funded program.
They're privately owned, but they are funded by Medicare and Medicaid.
Because the people have those programs,
That's where the
the
revenue is.
patients have those programs.
The revenue comes from CMS, through CMS, or through the state.
Right. So, but there is a difference, correct, of a privately owned entity that has people that attend there, and that's how that they are reimbursed for their services, is they filed or they bill Medicaid or they bill Medicare. I'm just trying to clarify,
Yeah.
right?
Oh, yes.
Okay. So the one thing that I didn't see in anything in your paper is quality of care. So have there been complaints at any of these facilities about quality of care, or they're not, if so, we haven't heard that here in this committee?
Well, it depends on the facility. I don't think you hear many complaints at Pleasant View, but I know at Riverbend, if you look at Nursing Home Compare, they're going to have 1 to 5 stars.
They're going to have what, I'm sorry?
1 to 5 stars.
1 to 5 stars.
And there should be a record at KDADS on complaints that have been filed against any facility. I would say it varies. Like I say, the one at Indian Creek and Rowe, there's probably very few complaints about that facility. Now, there was a special, I'll give you an example of a notorious facility in Wichita that was owned by Life Care Centers, it still is. It became a special focus facility because the care was so bad that CMS has that category that they won't even give them a 1 star. They'll put them on as a special focus.
Thank you, Dave. That would be my concern, is that honestly, if you're a private entity and you're making a profit, I don't really care. And good for you. But if you're not taking care of the patient, if you're not doing what you're supposed to do, if the state is, or Medicaid is reimbursing you for patients that are on Medicaid, Medicare is reimbursing for patients that are on Medicare, and you're not performing the service, there are complaints about that, then that would make sense. But as far as, hey, they're making this much money, and maybe they shouldn't be making this much money, I don't see them coming here and asking us to have a higher reimbursement. It seems like they're doing okay with the reimbursement that they're receiving. Don't know that we've had complaints with them, but I thank you for being here, and that would be more of my concern is, are they not providing the service that they should be providing and providing care?
Well, I think my concern is, does the price match the cost? Are we pricing what we're paying for appropriately? And if we can't see those leases and look at those labor markets, those real estate markets, or if we can't see what we're paying for their health insurance pools or their liability insurance pools, what I'm saying is, are we paying appropriately based on how those entities should be pricing their services and goods to us? We should have a pretty good handle on that.
But again, we already saw that was built into Medicaid, correct? And Medicare has the same thing in that it's not they're saying, we're going to price this much, and you say, okay, we have to pay you that. Medicaid is saying, no, sorry, it doesn't matter what you're asking us to pay you. This is how much your reimbursement is. So are they overcharging? Is that what you're saying? You feel like they're overcharging?
What I'm saying is, we don't know. What I'm saying is, it's not transparent.
But isn't there reimbursement like everybody else's reimbursement? I mean, you get X amount for this, you get X amount for that, you get so much per day. Isn't their reimbursement the same as other facilities?
No, I think the reimbursements vary in terms of what their daily bed rate's going to be. It's going to be based on their cost reports. But what I'm simply saying is, if we're buying property or leases as a government, we're paying for a lease price, we're paying for an insurance price, we're paying for goods and services that are bought by these facilities that we're reimbursing them for.
But we're only reimbursing that at a certain capped level, correct?
Right, but I think the government has an obligation and responsibility to look at those prices. Are those prices appropriate, or are we getting transfer pricing? And that's what we find when you have a network of entities that are subsidiaries of a parent corporation and are selling to each other. That's what we really don't know at this point. And I'm just saying we need to open that up and find out.
Thank you. Thank you, Mr. Chair.
Committee, further questions? I have a quick one for you, if you don't mind.
Sure.
Page 6 of your figure A1, that form, that kind of stood out to me because that's in my hometown. And is that very top line, does that say Form CMS? Does that indicate that it comes from the Centers for Medicaid, Medicare Services? Okay.
These forms, by the way, have a very thick set of laws.
And you indicated that statement below mission health 100% was fallacious in a way. So what would the state of Kansas do to improve the transparency as you called for?
Well, in this case, first of all, one thing we needed to improve ordinarily on the column 4, 5, and 6. Column 5 is what they're reporting in expenses. Column 6 are the adjustments made by KDADs, or the auditors. And then column 4 is what they're allowed. So they were allowed $219,667 as a home office. They're not really, they're just calling that a management fee, which is really puzzling to me. And we could talk a lot about this. And the McPherson facility, by the way, I'm sure the property is separated into a separate LLC. I'm confident because I looked it up. So that should be shown here. If that property is owned by Windward Health Property or Windward Health Partners, which really owns this set of facilities, then Windward Health should show up down here in the bottom form as a 100% owner.
Right.
This form isn't filled out right because they're supposed to show under B, column 2, who is the owner. There's nothing in that. They're supposed to show percentage of ownership, which would be, apparently they're saying 100%, and then they have Mission Health Communities in here.
To whom is this form submitted? Is it submitted to KDADS or is it submitted to CMS?
I get them from CMS. I don't get them from the state, but I'm assuming they're submitted to the state, which then sends them to CMS.
Further questions, committee? Seeing none, we thank you for your time.
Thank you for your time. I appreciate it very much.
And next, our final conferee, I would call Dan Goodman.
Good afternoon. Dan Goodman, Executive Director of Kansas Advocates for Better Care. I know it's been a long day for everyone, so I appreciate the opportunity to provide testimony. By 2030, more than 20% of Kansans will be 65 years of age or older. This, coupled with the understanding that we have about a third of our adult care facilities don't have adequate care to meet the needs now, that should highlight the importance of this discussion. I first want to compliment the legislature for their actions over the last 3 sessions. We believe the body has been very generous with the industry during this period of time. With that, we'd also believe it's time for a comprehensive reform, and this committee has an opportunity to set the stage for funding a better approach to meeting the needs of Kansans. We recommend that reform and changes reimbursement rates should be guided by the following. 1, an approach requiring demonstrated outcomes in order to achieve higher reimbursement rates, as this would increase the likelihood of improvement in quality of care. Past budget enhancements provided to the industry over recent sessions have not improved staffing levels in these facilities. A recent study ranks Kansas 46th in the nation for facilities with staff shortages. 2, any reform that include long-term care investment in case management options as well as institutional care. Diversification in Kansas long-term care funding is a wise investment strategy for Kansas. Data strongly suggests that our current approach of long-term care drives older Kansans prematurely into facilities. Kansas ranks 47th in the nation for low-care nursing facility residents. These low-care residents could be served in the communities longer, and we can divert or delay individuals from ever needing their institutional care. And 3, restoring safety net support such as case management to complement CanCare for elderly waiver, as well as a physically disabled waiver and a brain injury waiver. This investment would strengthen our system. Case management would greatly improve support to older Kansans and their families in managing in-home care needs and navigating community-based services and supports. Again, to reduce the likelihood of institutional care. In closing, I'd urge the committee to consider our recommendations, a more balanced approach with long-term care and a reimbursement system that rewards demonstrated results would bring about better care results and a more cost-effective system for all Kansans. Thank you. I'll stand for questions.
Committee questions for Dan. Representative Carpenter.
Thank you, Mr. Chairman. So, Dan, thank you for being here. We already do PACE and our SILs and our home health, and we have the Senior Care Act. We spend a lot of money doing exactly what you're advocating. So how do we improve on that? Where do we go from there? What are you asking for that we're not already doing in the way of keeping people out of the nursing homes?
Well, as I mentioned, case management would be a good start. I mean, a lot of older adults that are trying to stay in the communities have difficulty troubleshooting and managing some of their care needs. And that currently isn't happening on those 3 waivers that I mentioned.
And targeted case management through what organization?
There are still, the good thing about Kansas is we still have those provider networks that have some experience in implementing services such as case management for those populations. Obviously, the area agencies on aging are very familiar with providing case management to the frail elderly waiver, the Centers for Independent Living for the physically disabled waiver, and of course, the AAAs have also been gaining experience with the brain injured waiver through the assessments that they do through the ADRC.
Right, and we've added funding to each one of those this last 2 or 3 years to improve on that. Is that not correct?
I think there has been some funding, but probably not at the levels that you've looked at within institutional care.
I just was curious because, as I said earlier, we're kind of in the foot because we're talking about declining nursing home populations, and yet we're working on the other end of that, to keep, which I'm fine with. I appreciate, and I think that everybody ought to stay at home as long as they could. But what level, on top of what we're doing, can we do that? Senior care?
Well, I just think providing Kansas with as many options as possible as they try to make sure that their loved ones are being cared for and aging in place as long as they possibly can is a good thing for Kansas.
Are there some we're not aware of?
Well, I think that I do think that funding those community-based services better would make them more readily available. You know, one of the challenges that long-term care has is a lot of folks, they go into hospital settings. They may be getting served in the community. They go into hospital settings for a short-term, and they get like short-term hospitalization. And then nursing facility, hospital social workers, they get notice, you know, sometimes at 3:30, 4:30 in the afternoon that the patient needs to be out at 5. And so discharge planners look at finding care for that individual as they're discharging them at 5, it's a lot easier to find a vacant bed in a facility than it is to coordinate care in the community. If we could fund services that can help them get back home with services and make that as easy as finding a bed in a facility, we really have done something in Kansas for long-term care.
And so finally, we increased the targeted case management to $75 an hour. Obviously, it hasn't hit yet, but is that a good step towards what you're talking about?
I think that's probably good for the IDD community, but of course, those 3 that I've talked about, the frail elderly, the physically disabled, and the brain injury, don't have case management at all. So that helps with the IDD, I believe, but it doesn't even address the 3 populations that we're talking about.
Okay, very good. Thank you, Mr. Chairman.
Committee, other questions? Senator McGinn.
Thank you, Mr. Chair. And to follow up with that, what I would like to request from staff, if they can by tomorrow, because you start out with, we believe restoring the case management. So I'd be interested in knowing from what and when, what, was it 5 years ago? Was it a decade ago? And then just kind of see what improvements we have made, because, Representative Carpenter is correct in saying that we have tried to make small moves forward, but I don't know how far we are from where we might have been at one time.
Right. Well, I can tell you in 2013, when we went to managed care, is when those 3 populations lost case management services. So it's been through that a time that they have not had case management services in the community.
Okay. I don't know how easy it is, but if staff could come up with that sometime tomorrow. Just the trend in these, the frail and elderly, physically disabled that he has in his testimony.
I can tell you the data points hasn't changed since last year. We were 47th last year. We're 47th again this year as well.
Okay, but I just would like to know, did we give $100 at one time for one service?
Oh,
or
gotcha.
did we, and are we at $60 now? I just don't know. I'd like to have a frame of reference.
Sure.
Thank you. Thank you, Mr. Chairman.
Committee, further questions? Seeing none?
Thank you.
Thank you, Dan. Committee, Representative Carpenter made reference to the Kansas Medical Assistance Report earlier in the meeting, and he has those he's going to pass out, and they will become part of the permanent record for this committee. And while he's doing that, Megan has a couple of handouts. There were some questions posed to KDADS earlier, and they have put those on paper. And what was the other thing?
Carpenter wanted to say something.
Okay.
Just a sample of the.
Okay. Okay. So Megan has 2 handouts for us. And did you want to speak about that,
Yeah,
Representative Carpenter? Yes.
Have it here in my.
You have the mic.
All my papers here. So anyway, committee, this is very interesting if you like this kind of stuff, but we had some conversations earlier about the number of people in long-term care and that we insure in Medicaid. And it came up, cohorts came up, which is a classification of different people. There may be like 1,000 people in a cohort. And then the billing is out there on that. And it's just very, very interesting to see if you go through here. Of course, there's a page and a half of acronyms, but if you go through here, here's the spend on the first page. Page 1, here's the spend, and it would be going from July of last year until June of this year, because this is the new one. But we spend about, $380 to $422 million or $1,000. But anyway, if you go down here and you look in the next one, the next page 2, you'll see Social Security, aged, blind, disability. And if you go down to the bottom, it's CHIPS and M-CHIPS and all that. Then on the next page, you'll see the frail and elderly, down, oh, it's on page 4, I think.
Somehow it didn't make it down this way.
Oh, I passed them out earlier. Everybody had one on their desk. But anyway, so if you look through here, you can see exactly how many people we're talking about in these cohorts. For instance, long-term care on page 5, non-dual and dual. We have 18,000 and 176. Monthly average is 18,000. I'm just saying, this is just good information. Look through it. It'll kind of help you understand the Medicaid program. So if you have any questions, ask somebody besides me.
Committee, any other comments or questions? Okay, because of the hour, I think we will go ahead and come back tomorrow morning. It shouldn't take long to go ahead and finalize our report and our recommendations, but I'd like to come back with everybody fresh. We've taken in a lot of information today, and if your brains are like mine, it's fried. So it'd be good to just kind of look at this information tonight, formulate what you think your recommendations for the report should be, and then we'll just have a brief discussion in the morning. We should be done by noon. And with that, we'll be adjourned till tomorrow morning at 9.